well accepted in the US. We looked at the EPIC study, and if you use that threshold of 0.25 to suggest you shouldn't treat with antibiotics versus above it, you should treat with antibiotics, we do see that patients where we detected typical bacteria tended to be above that threshold, but these are 25-75% confidence intervals on these boxes. So 25% of the patients who we had a bacterial detection actually had less than the 0.25. If you look at atypical pathogens, it's actually 50% are below that threshold. So we can debate about whether you need to treat those or not, but they clearly are below it. If you look at our unknowns, they actually look like virus. And so it actually is consistent with this idea that a lot of what we are calling pneumonia is actually probably viruses. Now, there are some places that I think procalcitonin is very helpful and can be used. This is one of my favorite studies, looking at procalcitonin in patients who are admitted for congestive heart failure. And I can tell you there's a lot of antibiotic use because the radiologist says pulmonary edema, density in the left lower lobe cannot rule out pneumonia. And so there's a lot of antibiotics being used for patients who clearly have heart failure. If you look at overall, there's no difference in outcomes if they're treated. On the other hand, if they have a high procalcitonin level with a threshold that's actually lower than what is generally used in the literature, if you treat with antibiotics, it actually has a mortality benefit. So if they really do have an infection, whether it's pneumonia or not, if their procalcitonin is high, they have a worse outcome. The flip side is, and if you look on the right, is a procalcitonin that's at the lowest level of detection of 0.05. There, if you treat them, there is a worse outcome. So I think in those kind of equivocal cases, procalcitonin can be very helpful. Now, what we didn't find in the EPIC study, and we included many patients that met the old criteria for HCAP, is that we didn't see a lot of Pseudomonas and we didn't see a lot of Staph aureus. So Pseudomonas, we had 7 cases out of 2,000. Staph aureus, a little bit more in the ICU, about an even split for MRSA versus MSSA. And I think that what you've heard already in several times, and if there's nothing more that you carry out of this session, is HCAP is dead. I think that there are some studies that suggest that you can do better, and if you're going to try and use specific therapy for Pseudomonas or specific therapy for Staph aureus, you probably need to be aware of this study. It's a Japanese study. It actually, their healthcare system is a little bit closer to the US than what the European or other places around the world. And importantly, what they looked at here, two important things about this study. What they looked at is what pathogens are resistant to our usual care for CAP. So ceftriaxone, azithro, or a fluoroquinolone. And so if you get a gram-negative, but it's sensitive to your fluoroquinolone or ceftriaxone, it's okay. So when you look for overall risk factors, it's hospitalization in 90 days, antibiotics in 90 days, immunosuppression, non-ambulatory status or tube feeding. So this is picking up your nursing home patients that are really at risk for resistant pathogens, and then gastric acid suppression. Now, prior guidelines, and that is if you've got some risk factors that are unique to MRSA. So prior MRSA colonization and congestive heart failure, as well as hemodialysis, are unique to MRSA. And if you use these kind of criteria, the other important thing is that they were very good about getting sputums, much better than any other study in the literature. And what you see is if you only have one risk factor, the probability of MRSA or other CAP drug-resistant pathogens is extremely low, okay? As opposed to 2 factors where it gets a little bit higher, but mainly MRSA, it's when you get to 3 factors that you really have to be concerned about it. And I think that's the key with the whole HCAP thing is we said one of these risk factors and you should be getting triple drug therapy, when in fact I think that's wrong. There clearly are some patients who have MDR pathogens, but it's much less than the ones defined by HCAP. And this is where you need to use sputum, because Pseudomonas is rarely in blood. Pseudomonas is rarely going to, well, it will almost only be detected by sputum or lavage. Now, those risk factors, I think, skip what is an important thing, and I don't know that there's going to be any algorithm that's going to be easy to pick up these. If you live in a place where we see the USA 300 community-acquired MRSA, you need to recognize them, and diagnosis is not difficult. Anything you send down to the lab will grow staph, okay? Pleural fluid, sputum, blood, BAL, tracheal aspirate. The issue is recognizing and sending something and recognizing early, and these are some of the risk factors for those kind of patients. Cavitary infiltrates, rapidly increasing pleural effusions, gross hemoptysis, and that's the key. It's not blood-streaked sputum. It's pure blood that they're coughing up, because this is a vaso-invasive thing. It occurs in the setting of influenza. They have neutropenia because one of the toxins, and that's the key, is this is a toxin-producing strain. One of the toxins is PVL. The L is leukocyte, and they're actually assassinate neutrophils. And then skin rashes. And this is the kind of gross hemoptysis that I'm talking about. Now, this is what I think is going to be the future, is molecular detection. This is one of the studies we did because we are concerned about it. We validated a rapid diagnostic test that is commercially available, not approved for use in tracheal aspirates or BALs, but has been studied in both. And what you see is a very low or a very high negative predictive value. So if this test is negative, you can pretty much be assured that you don't have MRSA, and that's what we've been using to get away from using vancomycin, particularly in our intubated ICU patients. And I'll leave you with a thought that will not be in the guidelines, but is something that's really on the future, and that is the lung is not sterile, and pneumonia doesn't mean invasion of pathogens into a sterile space. And so a lot of what we may call pneumonia is actually dysbiosis of the normal lung microbiome, and that's going to be very difficult to detect, and it may not be a single pathogen or a single species. So in summary, the one-size-fits-all for diagnosis of CAP etiology is neither high yield nor cost effective. So what we did for EPIC, you shouldn't do. Culture-based diagnosis of CAP is frustrating and low yield, and I would say for couple of exceptions. One is a productive cough in these patients who have risk factors for Pseudomonas, maybe risk factors for other gram-negatives, so smokers, severe COPD, bronchiectasis. If they're coughing up green, yellow gunk, send it for a culture and make sure you take it down rapidly. In our intubated severe CAP patients, high yield to send tracheal aspirate, lavage, whatever you can get from them. I think given the frequency of viral CAP, the multiplex PCR is high yield. The real issue is we have limited antiviral treatments. There's more on the horizon, and that'll drive this, but I think that there is also, combined with procalcitonins in low-risk patients, it's probably appropriate to stop antibiotics. And I think molecular diagnostics are around the corner. That's really what we have with viral. I think we're going to see that more and more for bacterial, and it may already be here for MRSA. Thank you very much.
Thank you very much, Dr. Wondering, and I would like to invite Dr. Mark Matersky, who is going to be talking about treatment updates.
Good morning, everybody. I'd like to thank the organizers for inviting me to give this talk. So as Dr. Restrepo said, I'm going to be talking about treatment update. When this session was put together, I have no disclosures related to the subject of this talk. When this session was put together, I think there was a presumption that the guidelines would be out now and that I would be free, that we will all be free to talk about the recommendations. And you may have noticed they're not out. And therefore, I cannot talk about the recommendations. What I can talk about is the relevant evidence that it is informing the guideline panel that's leading to the recommendations. I'm not going to discuss questions for which the evidence is clear, as doing so would give away the recommendation. And of course, those are the ones that you least need help with, the ones where the evidence is clear. You already know what to do. So we'll start with an audience question. 65-year-old male with a history of COPD on chronic inhaled steroids is admitted with pneumonia. Pneumococcal urinary antigen. For those of you who don't know, the audience response is in the CHEST app on your phones. The pneumococcal urinary antigen is positive and influenza PCR is negative. Shortly after arriving in the floor, he develops hypotension, not responsive to 2 liters of IV fluid. He started a norepi. He develops worsening dyspnea requiring BAGPAP. There's no right answer to this. I just want to see what the audience thinks. Would you start IV methylprednisolone at 40 milligrams a day or prednisone at 40 or 50 milligrams a day? Yes, no, or you need more information? What more information? I'm curious. Anyone want to tell me what? I thought I made it a pretty clear-cut case, not saying one way or the other what you should do, but okay. Cowards. So we are tackling that issue in the guidelines. It's controversial, clearly. No definitive studies. It's controversial enough that there will be a pro-con on that issue published in CHEST sometime during the winter, I think. There are multiple RCTs. None are powered for a mortality outcome. They're almost all very small studies that even other outcomes of interest, they're not powered for. Several of these RCTs, right, RCTs are our highest level of evidence, but there are design flaws in several of these studies. They include early termination in one of the studies, which has probably received the most press because nobody died who got steroids, so they had to stop the study because of safety concerns. And when you stop a study early, it opens it up to potential bias statistically. Some of them were open label. Some of them had no allocation concealment, meaning that the people who were doing the randomization were aware of what the next patient would have been randomized to, which can also cause bias in terms of which patients are chosen for the study. At least one of the studies had imbalance of severity of disease despite randomization, just bad luck. Sometimes you end up with a sicker population on one side despite randomization. And many of the patients may have needed steroids anyhow, such as COPD. And if you withhold steroids from someone who has a COPD exacerbation, it wouldn't be surprising if they did worse. Luckily, that's showing up a lot better for you than it is for me. So this is the most recent of many meta-analyses looking at this issue. And I'll say that bottom line is the meta-analyses for non-severe CAP have not shown significant benefit of steroids. So we're really talking about the severe CAP population. And if you look at the studies that had low risk of bias for allocation and concealment, there was a trend that was not statistically significant, but we would say if the effect size is correct, 20% lower mortality, that we would say that would be a clinically significant improvement in outcome. For those studies that were of less high quality, there was a much higher estimated effect size of improved mortality, so 64% lower mortality. That did reach statistical significance, and when you took all the studies together, about a 34% lower mortality with steroids that was statistically significant. But again, all the issues that I mentioned in terms of the quality of the evidence. The other interesting thing that doesn't come out in the meta-analyses necessarily, but just, in my opinion, shows why we do in meta-analyses is, well, essentially none of these studies, except for one, I believe, showed statistical significance. Every single one but one. The trend was on the side of steroid benefit, every single one but one. And the only one that didn't show that positive trend was a study where the severity, the patients who were thrown into the severe bucket, it was done post hoc, where they went to patient-level data so they could look at this issue. But the severe patients in that study that were defined as severe post hoc, their mortality rate was quite low. It was 6 or 7%, much lower than the mortality rate in the placebo groups in all these studies. So in this study, the severe patients weren't that severe. So we have a meta-analysis that demonstrates benefit of flawed studies. And so that leaves us with a conundrum. What do you believe the meta-analysis is in these flawed studies, or do you not? And of course, it's controversial for that reason. And if it was a risk-free treatment, then maybe it wouldn't matter as long as it's not expensive, which it clearly isn't. If there's potential for benefit and no risk, it's easy to know what to do. But there's potential risk. Hyperglycemia clearly happening much more frequently, which may not necessarily be a huge risk to a patient on its own, but nonetheless, it causes problems. In one study, there was an increased readmission rate associated with corticosteroids. There's a potential risk of steroid use in influenza pneumonia. You could certainly counteract that risk by doing influenza PCR, and if it's positive, not give steroids, even if it's severe pneumonia. And if you're going to only recommend it for severe pneumonia, the issue is how do you define severe pneumonia, because it was defined differently in each of these studies. So those are the data that the panelists are dealing with on this guideline panel, and hopefully within a few months, 3, 4 maybe. 3 is optimistic. It won't be 3. 4 to 6 maybe, you'll know what the recommendation is. But I think there is the quality of evidence is not going to be high, and I don't think we're going to see a strong recommendation, and I think that leaves still up in the air. I mean, we're looking for a definitive study. Question 2. 75-year-old male with no significant past history presents with cough, low-grade fever, and malaise. He has no risk factors for drug-resistant organisms. His vital signs are normal other than fever, and he looks comfortable. His pulse ox is okay. He's got crackles, and he's got an infiltrate. This guy has pneumonia. You decide to treat him for CAP as an outpatient with close follow-up. Which of the following antibiotic choices would not be recommended by the 2007 ATS-IDSA CAP guidelines? Azithro, Levo, Doxy, or erythromycin? Which would not be recommended? Okay. So I don't like the way they actually show it as people are voting so they can be influenced by what other people have done. So anyhow, 61% said erythro, 32% said, oh, it's dropping. Actually, Levo is what was not recommended for outpatient CAP without comorbidities. It was thought to be too broad spectrum. Erythromycin, Azithro, Doxy were all the recommendations for outpatient CAP. Now, a lot of us, our pneumonia care is delivered in the hospital. As pulmonologists, we're not seeing the outpatient CAP so much. And somewhere I said, but to everyone else, outpatient CAP is more important. 80% in the US, approximately, is treated at outpatient. 4 out of 5 CAP patients are outpatients, so it's an important question. So the question is macrolides. What to do with macrolides? They're active against atypicals. They may lead to improved outcome by virtue of their immunomodulatory effect. There's a long history of using macrolide monotherapy for outpatient CAP. But there's macrolide resistance. Now, in studies, it's hard to find any good data about outpatient community-acquired pneumonia. So our experience is with inpatient. And limited effect of macrolide resistance would be expected, nor has it been seen, because we don't give macrolide monotherapy to inpatients. So it's not something that's really confronting us as hospital clinicians. So the question is what to do with macrolide resistance with this recommendation from 2007 where you could use monotherapy with a macrolide. So to sum that up, for an inpatient it was macrolide beta-lactam as an option for inpatient CAP. For outpatient, it's, as I said, a macrolide or doxy. But what they also said is in regions with a high rate, greater than 25% of infection, with high level macrolide resistance strep pneumo, consider the use of alternative agents, such as, it could be doxy or it could be a quinolone. And again, outpatient CAP is 80%. What they did not have, what they did not know because it hadn't been published yet, this study was published in 2009, but year 6 was 2006. They were already at that 25% range almost that they said consider, not using macrolide monotherapy. And at that time, most of it, so this ERM, that's the high-level resistance, and the MEF, which is the efflux pump, is the low-level resistance. It wasn't tremendously high. It was approaching 20% was high-level resistance. I should say parenthetically that there is no evidence, no good evidence that high-level and the intermediate or low-level resistant has a difference in outcomes between each other. And we'll talk about whether the resistance matters in just a second. Now, this is updated data from the CDC 2016, where now we have 31% macrolide resistant strep pneumo, and it's virtually all is the high-level resistance, okay? So we're dealing with a different era now in terms of macrolide resistance for strep pneumo. And we're dealing with a different era for macrolide resistance for mycoplasma, which is now 13%, at least in these cities in the US. Now, we've seen this slide a lot, but each in a different context, so I still have to show it. Mycoplasma was 2%, pneumococcus was 5%, and we saw data from Dr. Wondering that that may be low, it may be more like 10%. So macrolide resistance may matter in these organisms. Does it matter? And there are not a lot of great studies, but this is probably the best one, where they looked at patients who were admitted with bacteremic pneumococcal pneumonia who had failed outpatient therapy, case control study. And what they found is that if they were on an outpatient macrolide, they had that was much more common to be macrolide resistant organism than non-macrolide antibiotics, meaning macrolide resistance contributed to macrolide failure. And then these patients ended up in the hospital with bacteremic disease. So the guideline panel was confronted again with conflicting factors with respect to outpatient CAP. There's the potential for the improved outcomes with the use of macrolide due to the immunomodulatory effect as well as the coverage of atypicals, et cetera. But there's a potential for worsened outcome due to the high prevalence currently of high-level macrolide strep pneumo in the US. And then there's the increasing prevalence of macrolide-resistant mycoplasma pneumonia. So once again, I can't tell you what we decided, but these are the data that you can use to inform whether you agree with what we ultimately decide. Because just like with the steroids, there's some equipoise. It's not clear. You can make an argument either way. Other important, difficult questions. Role of procalcitonin in patients with clinically suspected and radiographically confirmed pneumonia. Can antibiotics be held if the PCT is low? Role of antibiotics in patient with detection of influenza. If you have positive influenza, can you not give antibacterial agents? And I would expand that to the patients who have a positive multiplex PCR for one of the respiratory viruses that Dr. Wondering talked about, whether it's rhinovirus or coronavirus, et cetera. Can we avoid antibiotics? The problem, of course, is that many bacterial pneumonias are post-viral events. The virus damages the epithelium and the bacteria can evade. Empiric antibiotics with patients with risk factors for drug-resistant pathogens, and we had a whole talk on that. Length of therapy, how many days? Follow-up chest x-rays, which used to be standard. People aren't doing them so much anymore, but I see that a lot of primary care doctors still do them. Is that right or is that wrong? So these are all other questions that we will be addressing. Thank you.
Thank you very much, Dr. Matersky, and I would like to invite Dr. El Alawi, who is going to be talking about ICU management of severe community-acquired pneumonia.
Thank you. I have nothing to disclose relevant to this session. The point being, everything you're going to see is based on the current, which is the 2007 IDSA ATS guidelines, with some commentary based, a lot of it's going to be repetition of what you already heard, because we don't have the current guidelines out yet, and we'll find out how that gets reflected in the current guidelines. So just kind of high level over what I was going to go over, what are we defining as severe pneumonia? What do we do for diagnosis? How do we select our antimicrobials, resistant organisms, and how do we support? So based on the 2007 IDSA ATS guidelines, the severe pneumonia is defined as either presence of severe acute respiratory failure needing invasive mechanical ventilation and or septic shock as major criteria, or three of the minor criteria. Something like tachypnea, low PA to FiO2 ratio, and the others that you can see. These have been further validated by Dr. Lee in 2015, and there were suggestions for could you simplify this? They still hold for the most part true, but potentially can or may be simplified. We'll have to see how that goes. What are the common pathogens? The common pathogens are still, and we're talking about common bacterial pathogens, still a significant proportion will be viral, the ones that we have not diagnosed. What do you do with those depends on the whatever epidemic is going on, if there is one, and what your multiplex guides in terms of therapy. Bacterial pneumonia is still most common is strep pneumo. We do worry about, are we dealing with resistant strains of strep pneumo, especially when it comes to an ICU patient. We have to pay attention to stuff like strep, Staphylococcus, gram-negative bacilli, and Pseudomonas, and other species. So this comes from, again, more of the CURB 65 and other publications that looked at the resistant or antimicrobial resistant strep pneumo, age of over 65, other therapies in the past. These are just suggestions to keep in mind. This person might potentially, not saying they are resistant, but might potentially have a resistant pneumococcal infection. You've seen risk factors for Pseudomonas being presented by several of the other speakers. They still hold true, need to pay attention to them, especially when somebody gets to the ICU. Now we're dealing with the sicker of the sick. You want to be aware of what kind of organisms are we dealing with. MRSA, same thing, severe disease, pay attention to the patient. Is this somebody who's colonized with MRSA? And we have the risk factors and recent illnesses and so on, things that suggest this person might be somebody who has an MRSA pneumonia. We suggest you do, the suggestion is you do make an effort, even if the diagnostic yield is low, we still need to make an effort to actually attempt to identify an organism in the ICU. So you want to get your blood samples for culture. You want to test urinary antigens. If you get expectorated sputum, great, get your expectorated sputum. If somebody is intubated, get an endotracheal aspirate, preferably before initiating antibiotics. Controversy of should you use procalcitonin or not. If you're going to use it, draw your baseline procalcitonin. We'll see what direction we get as a strong recommendation or not. But if you're going to use it, get your baseline so you can follow the trend as the disease progresses or as your treatment progresses. Having said all this, what do you treat them with, or which antimicrobial agent would you use? Treat the most likely pathogen that you can identify. We've gone with the list of statistically what's the most likely pathogen. Pay attention to the isolates in your ICU. What is happening in your local community? What's happening in your hospital? What outbreaks do you have? What kind of resistance patterns, both standard risks and risks in your particular locale, and what's your antibiogram looking like, and let that guide some of your therapies. However, if we go with the 2007 recommendation, a lot of which well, we'll see what the likelihood of it staying changed or unchanged, we'll find out, but the suggestion is use a beta-lactam plus either add a macrolide or a respiratory quinolone. We'll see how much of that holds, but that's the suggestion is a combination antimicrobial therapy. Again, this is based on the current or the 2007 guidelines, and we'll see the updates to that. If you're considering that the patient might have Pseudomonas, that's when you start considering your anti-Pseudomonal beta-lactams. You have to be very careful, am I considering Pseudomonas and something else? You have to keep in mind kidney injury, kidney damage, what combination am I going to use? Am I still going to use a combination of Pip/Tazo with Vanc if I'm considering a co-infection with MRSA and so on? So be very careful with what combination of antibiotics you would use based on your resistance pattern, but you would want to consider an anti-Pseudomonal beta-lactam for those, plus an aminoglycoside to get the, you want to make sure you're able to get the effective concentration into the respiratory system. If you are considering MRSA, then the question would be, do I use vancomycin versus linezolid? You'll have to be, again, based on your resistance pattern, am I using an anti-Pseudomonal agent as well with nephrotoxicity? So you're going to have to guide your therapy based on what other comorbidities or what other issues the patient has. Once you have, because we go after attempting to identify a pathogen, you're going to want to narrow your antibiotic once you have an isolate. So you would start broad, start empiric, but you want to go as soon as you possibly can or as soon as it's feasible to narrow the antimicrobial agent based on what you have isolated as an organism. Typically, how long would we treat them for? Most of the time, you end up treating for a minimum of 5 days. Standard criteria would be the patient should be febrile for 48 to 72 hours. They're not requiring supplemental oxygen more than their baseline. Most people do, not most, a lot of people in the ICU would have COPD or other conditions requiring oxygen. So we cannot say that somebody does not need an oxygen, but going back to their baseline, and they're no longer actively a high risk. 7 days versus 14 days for most uncomplicated, even in the severe, 7 days equivalent to 14 days. Most of the time we can get away with 5 to 7 days. Again, we're saying procalcitonin can be useful. You've seen the data earlier. That is what we have as data. You can decide, is it useful to me? Is it useful in my locale based on my epidemiology or not? Some authors recommend it. Others say use it with caution. So if you're going to use that, as the levels go down, then you can decide that with the clinical improvement and my levels going down, decide to stop or limit your duration of therapy. That's for uncomplicated or standard pneumo. Now if you have isolated an organism that your empiric therapy is not effective against, then the probability of you going longer is obviously there because you get your clock restarts with you effectively treating that particular organism. If you have an extrapulmonary infection, so if you have a patient who's bacteremic, who has other sites of infection, who's seeding infection outside the lung, then your duration is going to be significantly longer, depending on where this patient, or what's going on, what else is going on with the patient. Pneumonia, if you're dealing with now the smaller subgroup of pneumonia, those caused by Pseudomonas or one of the less common pathogens, again, chances are you're going to go a lot longer in therapy. Patients with complicated infections, necrotizing pneumonias, empyema, lung abscess, you can be treating those patients for 4 weeks or longer. At that point, the decision would be, do I continue intravenous antibiotic therapy, or do I go to convert intravenous to oral therapy? It depends on what agents you have. It depends on the organism that you've isolated that you're trying to treat. Steroids, we just heard about the data behind steroids. The data comes from multiple systematic reviews and meta-analyses. Nothing that's particularly powered to give you level 1 evidence. Kind of would question if it would give you level 2 evidence. We'll see about that. But the suggestion from these is there potentially can be a reduced mortality. There might be a reduction in the duration of mechanical ventilation, might be a reduction of hospital length of stay. Again, with the caveat that most of this is coming from meta-analyses. So if you're going to consider using them, it's usually somebody who's in sepsis, somebody who has respiratory failure, somebody with metabolic acidosis, or clearly an acute inflammation, such as a high C-reactive protein. Having said that, other adjunct therapy, standard ICU care, the standard supportive care that you would use for any ICU patient, as we would say, good critical care, antibiotics, and plus minus the adjuncts. You want to de-escalate your antibiotics early to prevent side effects and so on. I think that's what I have. So in summary, try to isolate an organism, treat with empiric antibiotics, focus or narrow down the antibiotic coverage once an isolate with resistance is available. Use your empiric or your epidemiologic data that's available at your location. Again, the guidelines recommend general statistics, but you want to refine care based on your specific location.
Well, thank you all for coming. Due to time, I would like to invite, if there are any specific questions, to please come by and ask the speakers, because there is another activity that is competing with this end of the session. Thank you very much.
Good job.
Thank you very much. It's hard to talk about something that is not there.
Hey there.
Amendment.
Bloomberg nuestro es maravilloso.
No, pero manejamos con interconsulta. Sí, sí. Sí, vemos todo. Sí. Sí, lo que estamos igual y que vemos en el internado. Sí, así que bueno, sea un tiempo. Muchas gracias, mucho gusto. Muy hermosa. La primera vez que me
No había tenido la oportunidad de escucharlo, he leído varios de estos, todo eso, pero bueno, yo mis años en y ahí nos quedamos. Cuando Luis estaba aquí en el campo de Diego Tapman, Pero entonces no, sí, 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 no, no, dale. Sí.
From Texas to Arizona, I did, yes. Last summer, actually. I've been there a year now. It's good. Thank you. Well, not that much drier, because Lubbock is fairly dry.
Oh.
I was setting it up here. Yes, yeah. Yeah, it's not Texas, I know, it's more Midwest. It's warmer. Yeah. It's, but weather-wise, it's closer to Midwest weather. But it's not as cold. So, like in Lubbock, we would get snow for a few days a year, and snow aside, it gets cold. You have a 30-degree temperature variation, it's freezing. So in Phoenix, in the winter, it's kind of really nice. It goes from like 40 at night, maybe, to 70 during the day, which is really nice. And it's not horrible, so the weather is nice. That's right. I think so. The fellowship program at Beckman is even bigger. And so, and there is this whole, we have to build a program. It needs to be, it's the University of Arizona in Phoenix. It used to be the Good Sam, then Good Sam VA program, then Banner University Medical Center program. And then the university and Banner merged in 2015, so it was, the program existed for a long time, but you take the community program, kind of making it more academic and, restructure and stuff like that. So, yeah, it's been, I think it's been good. Let's see. So much longer that lasts.
Have to be positive at least.
Oh, absolutely. No, absolutely. I mean, I was even going to Lubbock. I was like, yeah, this is going to be probably 3 years tops. Quite frankly, the biggest loss is
What is it?
How you doing? Nice session. How you doing?
Over here? No.
I was a little bit, yeah. How you doing?
Hey, Ellis, it's Trey. I was just making sure. You're talking about podium mic or the audience mic? Hello, Ellis? Oh, that's funny. Okay, I'll just do podium mic. Yes, sir. Testing, testing. 1, 2. Hello, hello. Good evening. 1, 2, 1, 2. Good afternoon. Hello, hello. 1, 2, 1, 2. I don't exactly know what we're looking for here. We're just testing mics out. 1, 2. Hello, hello. 1, 2, 2, 3. Hey, 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 hey. 1, 2, 1, 2. Hey, hey. Testing, testing. 1, 2. 1, 2, hey, hey, 1, 2, 1, 2, hey, hey, 1, 2, 1, 2, hey. Good afternoon, everybody. How's everybody doing this evening? Hello, hello, 1, 2, 1, 2, hey, 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 1, 2, 1, 2, hello, hello, 1, 2, 1, 2, hey, 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 1, 2, 1, 2, Sunday, October 7th, 12:15 in the afternoon. Hey, 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 1, 2, hello, hello, 1, 2, 1, 2, 1, 2, ladies and gentlemen, good afternoon, hello, hello, 1, 2, 1, 2, hey, 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 1, 2, 1, 2, testing, testing, 1, 2, test, 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 hello, hello, 1, 2, 1, 2, hey, hey, 1, 2, hey, hey, hello, hello, 1, 2, 1, 2, hey. Yes, sir. Oh, my phone died. Ellis, my phone died. My phone died. Hello, hello. My phone died. I'm coming back down because my phone died. No juice, because I have a really terrible phone. No juice. Coming back down.
4:30, 4:45 to 5:45. That's to 5:45. This one. I think this is the latest one so far.
Nope. Hello, hello, hello. Hello. Good afternoon. Hello. Hello. Room 213A, Henry B. Gonzalez Convention Center. Hello. Hello, 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 hello. Good afternoon. Good afternoon. Hello, hello. Hello, 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 hello. Good afternoon. Hello. 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 Good afternoon, good afternoon, good afternoon. Hello, 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 hello. Stuff's happening on the not the laptop, but the screen, the other screen. Hello, 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 hello. Room 213AB, 213AB. Hello. Hello, hello. Hello. Sensitive. Hello. Please assist chest staff by keeping aisles and exits clear. Please silence all cell phones and pagers during the presentations. Shit. To verbally disclose any or no. Blah, blah, blah. Hello, hello, blah, 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 blah. Hello, good afternoon, hello. Hello, hello. Hello. Hello, 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 hello. Hola, hola. Hola. Hello. Jello. Hello, Jello. Bum, 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 bum. Bum, bum. Hello, hello, hello. Wah, wah, wah. Wah, wah, wah. Wah, 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 wah. Hello. 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 Good afternoon. Buenos tardes. Hello. Ba, 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 ba. Ba, 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 ba. All right, I'll just read this. Please make the following announcements. Reminder, all sessions can be evaluated. No? Nothing? Okay. Hello. Ba, 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 ba. Hello, 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 hello. Hola. Hola. Ba, 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 ba. Ba, 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 ba. Ba, 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 ba.
Tony, come back. Can you call me on my cell phone, please?
What's up?
I said, are you putting brake slides or?
No, I'm not doing. We were. I'm overflow, and he's checking y'all's signal because
It's messing up.
yeah, down there, all sorts of stuff. I think he's actually. What's up? Yeah, I'm walking. You couldn't hear me at all? Hello? Okay. Yeah, yeah. Yeah, yeah. Okay, want me to hang up first? All right, hold on. I'm going to put you on mute. Hello, 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 hello. Good afternoon. Hello, good afternoon. Room 213A, 213AB. You can't hear? You can't hear that? Okay. All right. Hello?
Hey, bro.
Yeah.
All right, so where you at right now? Still 230, right?
213A?
Okay. So what I think could be happening is the DIs might not have, the pad might be off. So it might be way lower than the other ones with the pad that's on.
Mm-hmm.
So we're testing. Shit, I just lost the stream for that little. See, this is what's killing me. Why am I losing streams, man? Okay, what room are you in? 213 AD?
213AB. I mean, I could check all the cords while I'm here, but everything looks like it's plugged in, right?
No, you're good. It's not you. It's hold on one second. I'm looking at what they're trying to do. Because honestly, I don't know what he's doing in this room with these. I don't want to mess him up.
What's up?
No, I'll just hold on a second.
Mm-hmm.
Okay, because he's in the room. Let me try it again. I'm trying to get you back on screen so we can do this test. It doesn't look like it's going to work. What room are you next to?
214 to the other ones, the ones right across the hall.
214 or what?
Let me see here. Yeah. I'm back at the podium now. The box. On the table? Okay.
Okay, yeah. I feel like I'm too short to stand, like you can't see.
Can you use that microphone?
Yeah, but I don't want to sit.
Can you go like this?
Oh, that's a good idea. And then stand to the side. Yeah, because you're going to have the same problem as me.
No way. What do you mean?
I believe you're an inch shorter than me. When I look at you, I see you an inch shorter. It makes me feel better. Probably just to the
tried my personal. And in our Wirecast that are invited on Wirecast, and it does the same thing. Yeah. Yeah, because we did just like from his laptop, we just did like, hey, you go to Facebook and just type hit go live, and it works. So I'm thinking it's something to do with Wirecast possibly. Like if I just go to youtube.com and just like hit go live on the website, it'll work that way. But so I know. Yeah, I think it was. Yeah, and I think that might be a YouTube issue. Yeah, I think it's like YouTube server issues or something for like Googling it now. Media relations, security, legal, developers, nope. Content ID, site securities, and partners program. Okay, any help form? Yeah, they don't, everything, anything they would have would be an email. It looks like. Yeah, or by, like, the only number they have is a fax number. Crazy as that sounds. Yeah, it's like I can log in just fine. Re-logging in. Yeah. Yeah, I'm thinking it's something on YouTube thing. You're gonna need to call Charles and talk to him. Go Brandon. And let him know. Roger that, I'll be in there in a second. Yeah, yeah, you might need to call Charles and talk to him because he's determined that this is gonna work. No, that it will work. He thinks it's something I'm doing wrong, but I'm not seeing anything that's like out of the norm, other than YouTube. Yeah. Okay, I'll talk with Charles and then we'll see what we can do. All right, man. So I keep bothering you every weekend. All right. Off to my next room, and I'll text you an update and let you know. All right. Thanks, man. Bye.
doing the same thing as the, like, bringing the APT into the fellow world. How they work together. I think so. I think so.
I was just trying to decide if we should all just sit up here.
Yes, that looks a lot better.
Okay, copy. Thanks.
Hello.
Everything working?
Yes, ma'am.
Huh?
Yes, ma'am.
All
It's just
right.
restarting already.
Okay. Is there anyone in this room after us? Do you know?
I'm not sure, ma'am. I'm sorry.
No, that's okay.
The man outside, he might have more information on that.
guys don't have any, like, steps? We have a bunch of short people presenting who are not taller. Can you guys see my face back there? You can. Great news. Do you want me to check you?
Huh?
Do you want me to check you?
No, I'm a little bit taller than you, I'm good.
I don't think that you are.
Bonnier?
No, you're not. It's such a lie. It's so lying.
Which boneyard? Video. Go ahead. Do you have any slide advances? Yes. If someone meet me halfway, because I gotta put in 217D as in dog. Look by the screen. In the projector kit, there should be one on top of the shelf. Copy.
Okay, now it's showing it.
Yeah, I think it just needed a sync. We're still missing one from Dr. Haynes. They just haven't uploaded it.
Okay, and it just says your PC ran into a problem, needs to restart. We're just collecting some error info and then it's restarting now.
Yeah, that's
Thank you.
It's good to meet you in person. Absolutely.
Person I did Yeah, the food was good last night.
I'm Janet.
That wasn't me specifically, but good job. And the boss. Good job. Short. Just don't ladies at me. Yeah, nice.
Mine's not working. No.
Yeah, look at my life. I don't want to go home after this. Everything should be cool. No, I know. Well, I need to come back because I didn't bring the key, so I gotta unlock the bad one and unlock the good one now, so I'll be right back.
Brennan, Sean. This Sean. Overflow Sean. Go for Ellis. 210 is 230. Copy that, thank you. I've got you again, Brandon, thank you. I'll make sure that's delivered.
Pulling up that pulling up that IP address for you. 192.168.4277. 4277, yeah. All right. You seen it? All right. Okay.
super high. Sometimes if you don't feel like talking to allergies, it just kind of sits in my sinus. So last week I was so exhausted. There was one of those where you're like, I'm running myself ragged. This is going to catch up with me.
I don't know. Okay, so you also like don't pick
Even some of my friends who work on the next level, they're in the SICU, and I'm like, I never see you.
I keep bringing this down and just put it up. Because I'm so short.
It's a freebie. Free giveaway.
Okay. So
Our swag bag.
yeah, we'll give it another minute or two.
We sold out 2 months in advance. No advertising. 3 years. That's nuts. Wow. Yeah, we have that. So yeah, I did her.
Hey guys, we're going to go ahead and get started. Welcome to ICU Ready, training your new PA or NP to be a competent critical care provider. Hello to all of you who are joining us via Facebook today as well. We're going to go ahead and get started with hiring the right candidate. Before we go any further into the talk, though, I just want to let you guys all know that we are going to be doing a webinar series starting in January that's going to be running along the same themes as the topics we're talking about today, called Integrating NPs and PAs into Your ICU, Essential Factors. So if anyone is interested in participating in that webinar or would like any more information of that, just let us know at the end of this session. We'd be happy to take down your email address and get that information out to you as it comes out. And in addition, we're going to save questions for the end. So if anyone has any questions and we have time at the end, feel free to come on up and chat with us. So we're going to move on to hiring the right candidate. My name is Allison Wines. I'm a nurse practitioner at the University of Iowa Medical Intensive Care Unit.
So they know how to do that.
Oh, sorry. My bad. This is your instructions. Has everyone done a live polling yet? So you're going to go into your CHEST app, open the polling link, and then select this course. Okay, everyone got that? We're just gonna ask you a couple questions. Okay, I'm gonna move on. If anyone can't figure it out, let us know. Okay, so I do have one disclosure. I am faculty for CHESS Critical Skills for Critical Care course. And for the next 8 or 9 minutes or so, we're gonna be discussing ideal candidate attributes and understanding the difference between physician assistants, nurse practitioners, and nurse practitioner subspecialties. So, first one, who's here? First polling question. Get out your phones. Okay, so looks like we got some NPs, a few PAs, and a good amount of physicians as well. That's great. And where are you guys all working? Community, academic setting? This will just help us focus a little bit more to what your guys' needs are. It's a nice split there. About 60% community, 40 academic. All right, so first let's talk about how we got here. Having nurse practitioners and physician assistants in critical care is becoming a growing trend, but how did we get here? Why is this happening? We know there's a shortage of critical care physicians nationwide, and there's been a reduction in resident work hours over the last several years. You couple this with increasing number of critically ill patients and increasing amount of ICU beds across the country and the need for 24/7 care, and we've created quite a care gap. Some people are catching on to the idea that plugging these holes with NPs and PAs can be a really smart thing to do. So that's how you're seeing more of us in that spot. So we know why we're here, but is it a safe thing for us to do? We know that in general, physician assistants and nurse practitioners provide good care. Research says that over and over again. But what about in the ICU? Well, Landsberger and colleagues set out to answer this question in a medical intensive care unit. They compared the outcomes of patients that were cared for by residents versus acute care nurse practitioner teams. They saw no difference in 90-day mortality, hospital mortality, or ICU length of stay. Although, if we're being picky, ICU mortality was lower for patients on the acute care nurse practitioner team, and hospital length of stay was also shorter. So we know why we're here. We know that evidence is starting to show that it's probably safe for some of us to be here, or for us to be here. One thing I do want to point out about this study, though, is these nurse practitioners were very trained. And they were also working with fellows and staff physicians as well. And anyone who's thinking about putting nurse practitioners or PAs in their ICU should probably read this study. So we know we need help. We know it's okay to hire NPs and PAs. So before we actually hire anyone, we need to know what we're gonna do with them. What is their scope of practice gonna be? Are they just gonna be writing notes? Well, if that's the case, save everyone some time and energy and money and just hire a scribe. Or you could hire them to do some actual work for you. They could do procedures, orders, diagnose, all of those things for you, admit, discharge, whatever it is that you need in your ICU to be done. And then you need to know, how much time can I devote to training these people and onboarding them? Do I need someone who's ready right away? Or do I have some time to invest in these providers? And then we also need to understand that not every nurse practitioner and not every physician assistant is created equally. They all don't have the same educational background. They all don't have the same personalities, just like physicians, right? You would never want to take a family practice physician who hasn't been in patient care for 20 years and stick them in your ICU. Same thing applies with nurse practitioners and PAs. It takes the right person to be successful. So we're just going to go over a couple of the differences between nurse practitioners and PAs. Nurse practitioners are trained at either the master's or doctorate level. Before you can get into school, you typically need some nursing experience. Program lengths vary based on the degree you get and the specialty that you are focusing on, and it also builds on a nursing model. Compare that to PAs. Most programs are master's levels, take about 2 to 3 years, require a bachelor's degree, and some sort of patient care experience before you can be accepted. This can be anything from a volunteer, a nursing assistant, an EMT, a lab tech, some sort of something where they've done some patient interaction. And they follow a medical school model. They both are going to have their own clinical rotations. Nurse practitioners are going to be based on their specialty. So for example, a family nurse practitioner will focus on outpatient experiences, primary care, peds, women's health. Acute care experiences are going to be more hospitalist-based, inpatient focused. PAs have set clinical rotations. Every program is required to provide these rotations to their PAs. You'll notice that neither one of these necessarily include ICUs. For most NPs and PAs, it's an elective to go through an ICU. So that's something to think about before you're hiring them. Have they even been in an ICU, either as a nurse or did they do a clinical rotation? Do they have anything that shows that they have any idea what they're getting into before they step into your ICU? And then they both are going to be certified nationally, and they both are going to require state licensures. One side note for the nurse practitioners is they are governed by each board of nursing, so their practice patterns may vary a little bit state to state, but typically in the ICU, you're going to be working collaboratively with physicians anyway, so this is maybe less of a big deal in inpatient as it is as an outpatient. So NP certifications doesn't matter. So I think it does. Not everyone agrees with me, but I really think it does. Family nurse practitioners are trained to provide primary care, whereas acute care nurse practitioners are trained to focus on the stabilization of acute medical problems, prevention and management of complications, comprehensive management of injury and or illness, and restoration of maximum levels of health within an interdisciplinary and collaborative environment. Now that sounds like something more that you could build on to practice in an ICU for me. I will say that not every state has enough acute care programs out there, and there are lots of family nurse practitioners practicing in ICUs, and they're doing a great job, but they're practicing outside of their scope of practice, and that's on them to know what their scope of practice is. You need to keep yourself safe and practice where you were meant to be and where you were trained to be. There is a consensus model that has been developed in the nurse practitioner world. It was about 40 organizations came together and created this document trying to help standardize nurse practitioner care across the country. And one of their main points was keeping people where they were trained. So keep primary care providers in primary care, keep acute care providers in acute care. So should you hire a new graduate? So, yes, no, maybe. It all depends upon what clinical experience they have and what previous job experience they have, and also what you think their aptitude is. Is it someone who can put in the time? Is it someone who's going to dedicate to getting themselves trained up? And do you have the resources and times to invest in them? If you don't have the 6 months to invest in them, get them trained to do procedures, get their clinical knowledge up to snuff, and really get them where they need to be, you probably shouldn't hire this new graduate. You also want to make sure that they're going to stay, and I know that's really hard to predict. You don't know if someone's going to leave you in a year or 2 years, but you don't want to spend 6, 12 months in getting someone up and ready to go just to have them leave you, because you'll never catch up, right? And then a lot of hospitals are looking at offering residency and fellowship programs to help train these, so that's something, if you have a robust program, you might want to think about. You can maybe reduce their pay a little bit, give them a little bit extra education, and then in the long run, you'll kind of even yourself out. So an experienced provider. Everyone wants to hire an experienced provider, and that's great. I do too, and there are some real advantages in that. This provider is already going to know how to document, how to bill, how to write prescriptions, maybe how to do some procedures, and those are big hurdles to get over, and it takes a lot of time just to train those basic skills. But keep in mind that all experience isn't equal. So someone who's been working in, let's say, derm for the past 5 years may not have enough of their clinical knowledge left from their education where they're going to be able to hop right into your ICU. So maybe in that case, you are better off hiring a new grad who just graduated from a PA program and had an ICU rotation, or just graduated from an acute care program and has a really strong base and foundation that you can build off of. So, thank you guys. In conclusion, I feel like I could talk about this for like 17 hours and we only had 10 minutes. If you have any questions at the end, let me know. But I think really what we need to focus on is getting the right people and the right bodies in the position and then training them, like my colleagues will talk to you about in just a minute, before you can have a successful program. So with that, I will leave it to Joanne.
I'm just going to set my timer here so I don't go over. I am going to kind of tag team onto Allison's topic and talk a little bit about procedural training for advanced practice providers. I am a physician assistant working at Leahy Clinic, or Leahy Hospital Medical Center in Burlington, Massachusetts. I've been a PA for about 13 years. 10 of the last years have been as a critical care provider. So a lot of the things I'm going to talk about, I firsthand experienced kind of working my way through becoming an intensive care provider. Again, going through the polling, hopefully we'll do a couple in the middle here. Disclosures, just as Allison had mentioned, I too am faculty at the Critical Skills for Critical Care course offered by CHEST. Objectives for my talk is about 10 to 15 minutes long. We're going to discuss some common ICU procedures that can be performed by advanced practice providers and that are in fact being performed now, probably at this very minute, by APPs in this country. Understand a couple training options. Allison touched on one of them, or a couple thoughts. And then patient safety with procedures performed by advanced practitioners. So some of the common core procedural skills that we use every day in the intensive care unit pretty much vary around circulation and airway. So arterial line placement, central venous catheters, dialysis catheters, EKG monitoring, interpreting, cardioversion, transcutaneous pacing, whether it be subcutaneous or in placing internal transcutaneous pacing wires, airway maintenance of an open airway, bag valve, mask ventilation, intubation, intubation, pneumothorax management. And additional procedures that APPs perform are thoracenteses, paracenteses, lumbar punctures. Some APs also have been trained in bronchoscopy and PA catheters. The big thing when training an AP in procedures is to understand the indications, the contraindications, complications, and dangers of the intervention. And I'd like to even say this should be for any provider performing these procedures. If you don't know why you're putting in a central line, the fact that maybe you should start norepi and maybe not neosynephrine for your septic shock patient, maybe you shouldn't be putting that central line in. Understanding the basics of critical care medicine and why we do something is important. Understanding the complications and that your patient may die from whatever procedure you're doing is huge. So I think getting the right person into your institution and into your ICU and training that person is a big part of being successful. So teaching invasive procedures, how can you teach someone a new invasive procedure? I mean, there's residency programs, there's fellowship programs out there for advanced practitioners. We in my institution have recently started a critical care residency program. And the reason we did that was we had a lot of new grads we were hiring, and they ranged with super successful in 6 months to needing a little extra more time. So we developed this program in training them that's focused more on didactic, a little more hands-on, a little more extra time for them to learn while in the intensive care unit, as opposed to, okay, it's 6 months, are you up and ready? Let's go. It gives them more time to become a strong critical care provider. There are national conferences out there that do a lot of simulation, a lot of hands-on teaching. And then the big thing is on-the-job training with a mentor, a senior APP, and your attending physicians. And this is how I was trained. 10 years ago, I was thrown into an ICU, and that's how I learned. I learned a lot because there were physicians that were dedicated to teaching me, to taking time, to showing me the right way to do different things. And I think that's how, you need buy-in from physician leaders, from APPs that are senior level, from everyone that works together in the ICU. You need a big team buy-in. Incorporating didactic education, skills assessments with checklists, simulation, and then evaluating clinical performance at the bedside is key. And the big one that I want to focus on is simulation. I think simulation, you've all, I'm sure, have participated in many courses offered here at CHEST that involve simulation, and there are countless studies out there that talk about simulation and the success that you achieve with simulation in getting a successful provider performing procedural skills. This particular study looked at central line insertions in the intensive care unit done by residents, and it showed that residents trained with simulation versus non-simulator trained had better success rates in placement, fewer needle passes, less arterial punctures, and overall their skills were better than their counterparts that did not have simulation training. There are different types of simulation models out there. The more common are the mannequins. If you've seen central line placement with the Blue Phantom, that's a pretty common model that we use to train on. There are non-human tissue. I know they've used different animals just to get the feel of how to place a central line. Cadavers are a little bit harder to come by and a lot more expensive, but there's just lots of different ways you can use simulation to train your APP. This is a checklist that we use in my institution. So for anybody that would like to perform a central line or an arterial line, thoracentesis, paracentesis, whatever the procedure may be, you can design your checklist for that. And I have them show me on a mannequin. Show me the steps on a mannequin. I use a shoebox for central line placement before, just to make sure you know the steps before I let you touch a human. The last thing I would want is to have a complication, and that could, harm the patient, but also scar the provider doing that procedure from doing further procedures as well. So checklists and constant feedback are key as well. So a little polling. Let's grab our phones out there just to kind of get an idea of how many central lines do you all perform a month? 1 to 3, 3 to 5, less than or more than 5, or none at all? Working? Great, so we've got a little bit of variety. A good amount of you put more than 5 in a month. That's great. I can't say that I'm doing that regularly, but that's awesome. The bigger you get, the more diluted you're out, the less you get to do the fun procedures. And what about tracheal intubations? How many do you perform a month? Okay. So about 50% are performing intubations and 50% are not doing any. So we've got a little bit of a mix in the group. The reason I ask these questions are, everybody wants to know, and everyone always asks me, how many? How many make a competent provider? What's the magic number that you can say, you are good to go, bye-bye, you're a skilled practitioner? And there is no magic number, I'd like to say. I mean, we use arbitrary numbers. There are some papers that say 8. My institution says 10 successful line placements. Intubations are a different story. There's a lot more that involved in that, a lot more risk. So I think it's definitely institution-based and practitioner-based. The World Congress of Vascular Access deems clinical competence based on a global rating scale and not a number of procedures performed. So if you are starting a practice with APPs in the ICU, or you are currently in an ICU with APs, I don't want to say that 10 central lines are good to go. I would like to say that the more you do, the better you get. The more you do regularly, which is why I ask that question every month, the more skills you are and the more safe your patients can be. And that goes back to finding the right APP out there, taking the time to train them, getting them the central lines, getting them the procedures that they need to get their skill level up. Can APPs perform these procedures safely? Are they safe? Allison talked a little bit about that, what APPs can do in the ICU, and it is safe, and we are effective body of clinicians. This paper looked at thoracostomies performed by APPs and compared them to surgeons. It's a small population, but there were 27 chest tubes placed by surgeons, 24 by APPs, and the outcomes were not statistically significant or inferior. The surgeons in this particular review placed more chest tubes for hemothorax, the APs more for pneumothorax. Again, just the difference in that was not also statistically significant. So I'd like to venture chest tubes can be performed safely by APs. This particular study looked at residents and APs in a surgical and a trauma ICU, and they had 1,400 patients enrolled. Double the patients were on the resident service, double the patients had residents performing the procedures, and about 555 that the APs performed. There was only a 2% complication rate for the APs. Length of stay and mortality were similar in both groups, and none had procedure-related deaths. This is a very old study, but I put it in here because even in 1993, we were looking at, can people besides physicians do procedures? And what this study looked at was 500 A-line insertions by respiratory therapists. And this particular group took the time to train respiratory therapists to get them the number of arterial lines that they needed to become competent. And what they found was that a physician was needed in less than 5% of cases to place a central line. 85% of the respiratory therapists had a first pass success rate after training and after getting up their numbers. And they initially started with 3 to 4 successful placed A-lines a month and ended at 9 to 14. So I know it's old, it's almost 20 years old, but I think it just shows you, even back then we were looking at this, can people besides physicians do different procedures to help our patients? And most recently, this week actually, there was an article published by the Brits over in the UK looking at their version of advanced practitioners. They developed them about 2008, and this particular group, since 2011, has had APs in their intensive care unit. And they're rigorously trained. They have checklists, they have simulation. They are not deemed on their own or competent until they go through this training process. And what they found was that 95.9% of the central lines placed had a success rate. Transfer activity, which is basically there, they use APs to transfer patients on mechanical ventilation throughout the hospital to other institutions. And there were 91.6% uneventful transfers. And they also intubate there. And 89.4% of the intubations they performed, which is about 190, had a first pass success rate. So looking at this just published this week, advanced practitioners, whether it's in the US or other countries as well, are a great addition to critical care management in a collaborative way, as long as you take the time to train them, to teach, and to get them the exposure that they need to be competent. Thank you.
Excellent, thank you. Good afternoon, everyone. My name is Jana Landsberger, and I'm a nurse practitioner in the medical ICU at Vanderbilt Medical Center. And I'm going to spend the next 10 minutes or so talking about ultrasound training specifically for advanced practice providers in the ICU. As I additionally am a faculty member at the CHEST Critical Skills for Critical Care course. So today we're going to talk about the importance of critical care ultrasound training, how to implement ultrasound training for the advanced practice provider, and then talk about a few of the good available resources we have to help with this. So just the first polling question, are you currently proficient in point of care ultrasound in the ICU? I think this is actually a really fun question to answer. Because if you looked at our faculty members in the ICU at Vanderbilt, if you took all the attending physicians, all the fellows, all the nurse practitioners, I think we would be at 50-50, which is what I'm expecting. Y'all are so lovely demonstrating for me. So I appreciate that. And I think this has really just been recent in the past 5 years that we're at 50-50. I got formally trained about 4 years ago, and probably 8 years ago, hardly anyone in our ICU was trained. So this is really something that's changed a lot over the past 5 years. So that's a perfect demonstration of what I meant to say. Have you been to a formal ultrasound training course? So for those of you who specifically said you were proficient, is it a lot of on-the-job training, or do you find that it's most helpful to go to a course? So it looks like about 60% of y'all have been to a formal ultrasound training course. I think it's really important that you invest the time and the money into providing formal education. So first, I just wanted to talk about this question. You're hiring a new provider. Allison talked about the differences between hiring a new graduate and an experienced provider, and what can you expect? Are they going to be trained in ultrasound? Well, it kind of depends. So there are really the two avenues. With a new graduate, whether you hire a nurse practitioner or a PA, you should know that there's currently no formal education required in school. There are electives available, but these are generally going to be not a lot of hands-on time and very much in the classroom setting. So if you are hiring a new grad, they might have been introduced to the topic, but really are not going to have any clinical hands-on time yet. If you're hiring the experienced provider, if they've worked in the ICU setting, it's very likely that they are trained, and they might even be better than some of your other colleagues out there. But the important thing to know is when you're hiring a new APP, whether they're experienced or not, ultrasound training can be completed in their 3 to 6 month orientation. So if you already know you're going to invest in their training, which everyone should, it takes 3 to 6 months. They can be proficient in ultrasound with the right resources during that training time. So it's not going to take anything additional. A couple reminders here. I think I'm probably preaching to the choir, but this is something that everybody is capable of doing. There's study after study that shows that it doesn't take a cardiologist to get basic echo windows and be able to very loosely interpret them as whether the ejection fraction is normal or help figure out the etiology of shock. This is not very advanced. But everyone really needs to know how to do this. It's now standard of care that every frontline intensivist be trained in how to do this. But this requires not only training, but a lot of continual practice. So like I said, I went to the critical care ultrasound course at CHEST about 4 years ago. When I went, there were, I think, 3 or 4 physicians from Vanderbilt that went with us and 3 or 4 nurse practitioners. So we go through the 3-day skills course, we come back home, some of us use ultrasound and some of us don't. Well, fast forward a couple years down the road and one of the nurse practitioners came home, never really used the skill, now doesn't feel competent anymore and wants to go back to another course. So this is one of those, you have to use it or you lose it. So make sure that you have continual practice. And formal training programs are a great place to start, but you really need some on-the-job guidance. And that can be performed, the on-the-job guidance, by a fellow nurse practitioner or physician, as well as a PA. So how are you going to get them trained? A lot of people have places to get trained at the institution. I do want to do a plug for the CHEST courses just because the facilities there are amazing. And the simulation experience and the low faculty to learner ratio is really top notch. And it's not something that we're really able to provide in our institution. Hopefully y'all are. But the first course I attended was the Essentials in Critical Care by Paul Mayo and his colleagues. And then also the CHEST Live Learning course does do some ultrasound training. But again, the most important thing is to practice. And I think that's one reason why training as a team works really well. So the model at Vanderbilt where we trained physicians and nurse practitioners together works really well because then when you're rounding on patients in the ICU, if you don't feel comfortable with the windows that you're getting or interpreting the image that you get, then someone else who's been trained with you can help guide you through that. I really encourage you to consider incorporating ultrasound into your daily practice during rounds. If you don't have time on rounds for every patient, at least pick out 1 or 2 patients where you're trying to really answer a specific question about etiology of shock or response to treatment, because that really helps. If you don't have time on rounds, then consider doing this on each and every admission, which is what I do. When we're admitting a patient, the ultrasound machine just rolls into the room. If we have multiple providers there at the same time, we have one interviewing the patient or family member to get the H&P while the other is doing an ultrasound. And then really consider doing it during when the patient is declining. If the physician is not there to help the APP during the time of training and able to do the ultrasound exam together, a lot of times what I will do is I'll save the images. Almost every ultrasound machine is capable of this now. You can either save the images directly to the ultrasound machine or to a flash drive, and then really take the time to review those images with your advanced practice provider. That can help you give them feedback about their technique and also help them interpret the studies. Another thing you can do is consider having monthly ultrasound rounds. This is something that we do at our ICU. It's actually mainly for the fellows, but we're always invited to tag along if we'd like. Or an emergency medicine physician credentialed in ultrasound comes up and they have a time where they just review different cases with the fellows and nurse practitioners about different ultrasound techniques. So it really takes a lot of practice and it really takes a lot of upfront investment. There have been a lot of physician colleagues have not gone on through the training with us, and they appreciate our ability to obtain the images and interpret them, but I think it's really a nice thing to invest in practicing as a team. Thank you.
Good afternoon. So I am DeMons Haynes. I'm at the University of Mississippi Medical Center in Jackson, Mississippi. And I'll let Susan introduce herself, and we're going to do this part together.
We're doing a tag team. I'm Susan Corbridge. I'm the Associate Dean for Practice at the College of Nursing at the University of Illinois, and I'm a nurse practitioner with pulmonary medicine.
So again, now everybody knows how to use the polling, thank goodness. We don't have any disclosures related to this. And here's our question for you. Do you have NPs or PAs and fellows in your current practice setting? Very good. So the vast majority of you. So hopefully we'll give you some information that will be helpful. I was the fellowship program director up until a few months ago, so we've done a lot at our institution. We'll be happy to answer some of those questions. So really we're going to talk a little bit about reviewing some data that supports, which you've heard a lot already today, utilizing NPs and PAs into your academic teams. You've heard in general, but we'll talk more about academic teams. We'll summarize some of the data for the staffing models, and then hopefully give you a few helpful tips for your NPs and your PAs. Almost 250,000 NPs so far licensed in the United States, about 115,000 PAs, and about 10,000 of those list the ICU as their primary practice site. So this again is more data that says this is happening now. It's not something that's going away. We have to be able to build integrated teams, and that teams work well together. And we're specifically going to talk about the fellows and the APPs in this talk. Good news, more data also about positive outcome and quality of data when we're utilizing our APPs as well. You see some references here that you guys could look at. But that's also very helpful, as you've heard on some of the previous speakers talking about some of the data. So how about burnout? So wellness is the end thing to talk about right now in medicine. This is some specific data about trainees, actually, not just physicians. The first article there, if you look at the #1 reference, talks about burnout in critical care fellows, specifically in third-year critical care fellows. So those are the ones that are just getting ready to go into practice. And so if they're already having issues with burnout, what can we do to try to help those critical care fellows? We know the ICU is a stressful environment. It's a high-stakes environment for all of us that work there. But some of the things that we know is that sharing this care with our interdisciplinary teams, with our APPs, and having a high-functioning team, right? This is going to be extremely important. It all improves job satisfaction and professional satisfaction. So that's one of the things that we can look at and how we can help with these teams and make them more successful. A recent study that Susan was actually involved in, and she could talk about from the National Academy of Medicine, talks specifically about these high-functioning teams and the high-functioning teamwork, and that's a strategy that we can utilize to optimize wellness for all of our providers. Again, I've already said it, but this last bullet point just talks about building the optimal teams. You know, you're always going to have some individual fellows that have some issues. You're going to have some individual nurse practitioners or PAs. And the whole theme is about, #1, patient care. We want everyone on the team, all our PAs, all our NPs, all our fellows, to hear it from the attending and hear it amongst each other that this is about the patient. Let's take our egos out of the way. That it happens so often, as we all know. But if we can bring it back to patient care, this is about the patient, and try to center the group around that, then we can usually find some common ground. There's always going to be one or two that we might just have to invite to find opportunities elsewhere. That's fellows and APPs, right? Because we don't want them to disrupt the entire team. That happens on both sides. So I think I'll transition.
Okay, all right. So what do we know about best practice and really in looking at how do we make this work? What models are out there that really work? And as we know, unfortunately, there really are little to no data on how to really make this work the best and go well. There are some great articles that are out there by different groups. Vanderbilt had a fabulous article. Sloan Kettering has had a fabulous article out there. But lots of different separate articles looking at, you know, what kind of models are out there. We really need a lot of data, and unfortunately, we just have very little. So there are also ICUs, as we know, that have a lot of different configurations and how nurse practitioners and PAs are actually incorporated into them. So again, there's little standardization, and so it's hard to really say what is the #1 model, what's the best model to use. We also have data that are lacking on strategies to promote collaboration among PAs, NPs, and fellows. So my big push today is I really think we need to get out there and make sure that we are collecting more data, that we have more data to look at, to know what are the best models, as well as how are we going to then take that back and inform our programs. One thing that I would like to do, I was acute care nurse practitioner director for over 12 years, and I would love to have more data to take back to our programs so that we know better how to educate our practitioners for transition into practice. Again, very limited data, really looking at fellows and fellow trainees that work with NPs and PAs, and again, that's our portion of the talk today. There's one study that I could find that actually really was data-based. It was a very large cross-sectional national survey. It looked at 331 ACGME-approved adult critical care fellowship training programs. So that was not just medicine, but surgery, trauma, anesthesia. You'll see they had a very poor response rate, though, only about 37% response rate, unfortunately. So again, not very robust. But what they did find, they looked at the program directors, fellow program directors, and the majority of the fellowship directors really felt that having an NP and a PA in their environment actually enhance the training of the fellows. So I would also like to really call for looking to see what the fellows think, looking to see what the NPs and the PAs think. So again, we can better inform our practice. So I think there's a lot that we really need to do. There are also other challenges reported in the literature. I found several articles really looking at there were challenges about incorporating NPs and PAs together, but they just were more editorials and not data-based. So recommendations, and again, some of this is not data-based because we don't have a lot of data, but some of the recommendations taken from the literature, taken from our experiences and from experiences of others and some of our colleagues too, is piggybacking on what Allison said, really looking at as particularly the type of NP that you are hiring, making sure that the scope of practice is what it should be, acute care specifically, and making sure they have the acute care competencies, I think is extremely important, that the scope of practice is aligned with the population that you're taking care of. Also, we do have limited data that compare NP and PA fellowships with equal work time and a proper orientation. So again, as Allison mentioned, there are fellowships that are popping up, or actually I think you mentioned that as well, Joanne. Fellowships are popping up, but we have limited data on is that imperative compared to having a really great orientation and something that's definitely getting people up to speed. One thing though that Allison also mentioned that I'd like to piggyback on as well is that NPs and PAs, typically even acute care NPs, some of them don't have a lot of ICU time in their program. So, you know, of course, people are going to need specifics and specific training when they come into any type of subspecialty. I think this all requires a change in mindset and culture. And Demond and I had talked about this a lot. Really, you know, this is the new wave of healthcare and incorporation of teams, and so requiring a whole new change in the way we're leading. I think it's important to have an MD and an NPPA lead together that are working together, that make sure, you know, this is a team-based approach, and again, with the patient at the #1 piece. And one thing that I've seen that has worked well, we get a lot of consults where physicians will call us and say, I really want to hire an NP into my program or into my unit, and what's really the best way to do this. We've worked with a lot of people about growing your own and, you know, developing your own programs, like Joanne had mentioned that they did, about training programs, and really also reaching out to program directors of NP programs, PA programs, and maybe you could incorporate and have new programs for training even of the students. And that's a way to work with the fellows as everybody's working, you know, they're working with students as well, NP and PA students, and I think that's an important piece as well, and that's been helpful. But one thing too, focusing on the interprofessional core competencies as you move forward, looking at values, that's important. Mutual trust, mutual respect comes from the whole piece, and understanding the roles. I think role transition and role clarity. I know I had been an ICU nurse for several years before I went back and became an ACNP, and when I did when I started working in the ICU, it was, even though I had been an ICU nurse, it wasn't until I really worked with the team of fellows and attendings, and we had pharmacy, that, you know, I really realized what everybody's roles were. So it's not until you really get in that team that you realize that. And then communication, of course, is key. Other things, I think, and I think you want to talk about this, we'll let you come back in here.
So to really make the team work well, specifically what we're talking about is with your APPs and your fellows, is setting expectations up front with your new hires. Sometimes even with the folks that are there, if you may have to start over and say, hey, we want to put everybody on a fresh page. Just start with the expectations for the APPs, for the fellows, the attendings, everybody, still talking about the teamwork, letting them know up front what's happening. clarifying the roles. This was alluded to, we talked about a little bit before the program started, for what everybody needs to do on the team to make sure that we're providing the best patient care. And talking about the reporting structure, not that it has to be a hierarchy, just how do we know for lines of communication. So just setting those things up front, not saying you're over this person, you're over this person. It's really about a reporting structure for improvement in patient care. And then talking about the whole goal, again, to reiterate, is great teamwork, great patient care. We know the data is there to support these multidisciplinary teams and how we can do it, and the work with our APPs. We invite our APPs, we have conference for the fellows every week, Wednesdays and Fridays. All the APPs are always invited to the conferences. Some of them, of course, are they're more likely to come when it's more dealing with critical care. They come sometimes to the pulmonary conferences as well. But it's a teamwork, so always invite your APPs and say, we're having conferences here. We even invite them to our social gatherings when we have a party to welcome new first-year fellows. We always invite the APPs that they come there, the Christmas party. So, yeah, we talk about the work things, but they want to be a part of your team as well. So there's a lot of things that we can do just above the day-to-day work activities that can make them feel involved and make everybody a part of the team and really demonstrate, instead of just saying we're a team, but to demonstrate that we're a team and this is how we work together.
The other thing I just quickly wanted to close on was saying that, and again, and Jana talked about this, but training together and going to case conferences, as Damon mentioned, but also, going to CHEST together, doing training together as a team, I think is really a way to enhance and support the entire teamwork. So just to close off, I think our future action, we need more data. I mean, there just are not a lot of data out there, essentially none, that really look at what is the optimal ICU structure in a setting that incorporates NPPAs and fellows together, and what are really ways to promote collaboration between them, and also looking specifically at job satisfaction. We know, in the nursing data in particular, great communication and good collaboration will keep nurses, they're very satisfied with their jobs that way. We want to prevent burnout. We want to increase job satisfaction for everybody involved. So again, we need more data to how best to do this and how best to inform care. Okay? All right. Thank you.
Okay, I'm Jim Dargan. I'm an intensivist at Leahy Clinic in Massachusetts, and I'm going to try to give you a broad overview of training a competent critical care provider, advanced practice provider. And I'm going to touch on a lot of the other things people have mentioned, hopefully kind of tie everything together for you. So we went through the polling. So disclosures, I also teach at this course, a lot of us do, and I'll actually mention the course later in the slides and bring up that conflict again. So learning objectives are to be able to describe some of the challenges in training APPs in critical care, and then understand some of the key components of really getting a high quality orientation program. And I'm really going to focus on a new grad APP for this talk. So question, how long is your onboarding and orientation process for a new grad? Again, this is somebody just coming out of school. So 0 to 3, 3 to 6, more than 6, or they don't have one at all. Yeah, it's a little bit, looks like a little bit all over the place. I think, anecdotally, I think most places are around 3 to 6 months, but that 27% number, that's about what's been published in the literature. Probably about a third of hospitals that have APPs really don't have any formal onboarding or training program in place. So these are some of the challenges in training APPs in critical care, and others touched on these. And I think the big thing that we're all sort of highlighting is the training is really variable for NPs and PAs, and some have little to no exposure to the ICU in school. ICU practice, as we all know, is complex. It requires high-stakes decision-making, and that can be challenging for a new provider jumping into the ICU. And then on top of that, you have to be able to do procedural skills to work effectively in the ICU. So on top of the cognitive skills that are required, we have that added layer of complexity to the training of new APPs. And so if you're thinking about developing a new program, it does require a fair amount of planning. I think having a lead APP really help design your program and implement it is the key. But you're hearing the message that you need to collaborate with physician colleagues too. And I think you do need physician leadership involved in designing a program and implementing it, not only for oversight, but also to help other physician colleagues get involved in some of the educational activities for these APPs, and then help through the process of evaluating the APPs and really determining competency. So, you know, a competency-based orientation program probably at a bare minimum should have some sort of orientation manual for the new APP. It should have basically their job description, and obviously it'll have sort of a progression of responsibility through that training program, and that should be all spelled out for them. They should have some basic ICU policies and procedures listed for them, and then there should be some guidelines on documentation, you know, how they're recording what they're doing for patient care in the medical record, and then some guidelines around billing, and particularly if you're co-managing patients with physician, providing guidance on how you're going to mesh the billing with APPs and physicians. You need to have some educational resources available for them in that packet, and I'll go over some of those in more detail in a minute. And then the milestones and timeline for achievement of those milestones, I think should really be clearly laid out for them and be transparent about what the expectations are. You should have some evaluation tool for determining the competency, and again, that tool should be available to them so they know exactly what they're being measured on. And I'll touch on mentors in a second, but should have some mentor resources available for your APPs. So, you know, as the APP gets into the actual training program, I think the clinical experience is really the key to training a high-quality APP. They should be integrated into the critical care team. They shouldn't be sitting on the sidelines. They should have active clinical decision-making, I think, really from day one, and then have that sort of progressive responsibility as they meet their milestones and are becoming a competent provider in the ICU. You may supplement their time in the ICU with some off-service rotations. That will depend on which ICU you're training your APP for. You know, in our medical ICU, we think about sending patients with nephrology or infectious disease to sort of increase the depth of their knowledge in some of those common subspecialties that we're consulting. And then you need to have a curriculum set up for the APPs, and that should involve reading materials, didactic sessions, and as others have touched on, simulation as well. So I just put up an example of some of the reading materials we have available for our APPs. This is an online repository, and basically the APP can go on there, pick a topic that they want to read more about, open up the folder, and there's some papers there. They don't have to dig through the literature and try to sort out what's important and what's not. So that's the foundation, and then they can build on that, but it at least gets them started with improving their knowledge base. This is from a paper that was published at a University of Maryland, talking about some core lectures and didactic sessions that they give for their APPs. You can see it's a big list. It's a lot of material to cover. And again, in that sort of spirit of collaboration, if you have a residency or fellowship program, you're probably giving a lot of these lectures for your residents and fellows, and just invite your APPs to those lectures so you don't have to reinvent the wheel. The other thing I'd say is if you don't have the resources to do formal didactic and teaching sessions, even just doing a 10 or 15-minute session on some of these topics kind of at the end of the day when you're working with your APP colleagues, I think can go a long way in helping train them. Simulation was mentioned quite a bit, so I won't harp on it, but I really do think this is important, and particularly in critical care practice, to do simulation, not only for procedural applications, but also high-fidelity simulation. I think really enforces team training, leadership skills, and then helps those APPs really make some higher stakes decisions, but in sort of a lower pressure environment. And then I mentioned this before, but I think mentors are really, really key too. And I think having an experienced APP serve as a mentor for your new grad can help, basically show them the ropes, answer questions about issues that come up with ICU policies, sort of the clinical practice patterns in the ICU, issues with billing and documentation. But I think also having a physician mentor is important too. And I think what we've seen at our hospital, that physician APP relationship that develops, carries on past the orientation phase and develops sort of a lasting professional relationship with that person. And I think what we found is our physicians tend to push our APPs into things outside of clinical practice, getting them involved in quality improvement, in teaching and research. getting involved in committees throughout the hospital. And so I think that improves job satisfaction and ultimately retention. And you know, it was mentioned before, you don't want to train an APP for 6 months, they're competent, and then they leave. So, so I think that's part of really putting some investment in the APPs. You know, you get the idea that this is a lot of resources and a lot of time put into training, and a lot of hospitals just don't have the resources to do this. There are national courses out there that are geared towards training APPs, and CHEST offers one. Several of us teach at this course, so we're certainly biased, but you know, I think this will give you a foundation. It's not everything your APP needs to know in one course, but I think it's a good foundation, teaches them a lot of practical skills for working in the ICU. And there are certainly other you know, courses out there that are geared towards novice ICU providers as well. So as your APP is going through the training program, you need to have some assessment of their competency. Generally, what we do at our hospital is do a weekly evaluation of our new APPs. So we do a very formal written evaluation, and we also give them verbal feedback, let them know what they're doing well, what they need to work on. And then we sort of pool those evaluations, and over the course of, say, a month or a quarter, we'll put all those together and review them with the APP. And I think others have said this. I think a timeline of around 3 to 6 months is reasonable, but you certainly need to be flexible. That can't be set in stone. There are some folks will kind of breeze through an orientation program and probably don't need the whole 3 months, and others will need some time beyond the 3 months really to be competent. So I think you just need to be flexible and keep that in mind. So this is just an example of an evaluation tool that we use at my hospital. So you can see we do a very formal, fairly rigorous actually evaluation of each of our APPs on a regular basis. And then finally, you know, if your APP is struggling through the orientation process, you know, I think it's important you'll identify those issues on the evaluations, give them the tools they need to work on those areas, put a clear plan in place for meeting with them again and assessing their progress. And then generally, if things aren't going well and you're having to, you know, work with your APP for one issue or another, generally extending out the orientation program is I think, probably a reasonable path for success. And that's all I have. So thank you for your time.
Okay, well, thank you everyone for coming. We have about 5-7 minutes left. I think we were all so worried that we had so much to say in 10 minutes that we spoke too fast. So if anyone has any questions, you can step up to the mic or come up and talk to us, or anyone have anything they want to say? Any thoughts? Yeah. Sure.
One of the issues with the FNP certification, our facility has hired several in the acute care role. Yep. And I raised the point from a legal standpoint of not being able to defend that if we were to be questioned on it. You know, how were you prepared for this situation in which you didn't handle correctly? Right. So one of the physicians that I worked with posed the idea that the training comes from on-the-job training, and so is that a valid point?
No. I mean, that's what's that? Yeah. So I think we all have a lot to say. I just want to say, first of all, I think it varies state to state. So I will fully admit I have FNPs working in my ICU. What I tell them is that they should look into a bridge program, because there are bridge acute care programs. Not everyone has done that or has the resources to do that. In Iowa, where I'm from, the onus is on the practitioner. So if you're the FNP and you're working in the ICU, it's on you to know that you shouldn't be working there, or if you make a mistake, it's on you. So every state is a little bit different, so you have to know your laws. Jana, go for it.
I don't know if y'all can hear me. I work in Tennessee, and the director of advanced practice nursing about 10 years ago was a nurse practitioner who was also an attorney, and she really developed the program. Before she came along, we probably only had 200 NPs or PAs in the Vanderbilt system, and now it's well over 500. And she really implemented advanced practice nursing and PAs in the ICU, and she felt very strongly for our institution that it would only ever be ACNPs. So over the past 10 years, we've only hired ACNPs and PAs for the ICU. I don't know if it's actually on.
I think it might be.
Is it?
Yeah.
Is it on? Okay. There are many, as Allison pointed out too, really great bridge programs. There are many online certification pieces that you can get. University of Iowa has a fabulous one. I don't teach there, but I know they've got a great program. But there are programs all over the country, and it really is important that that people are practicing within their scope of practice. There are many states that are clamping down on that. I know Texas in particular, they will not let FNPs be work in the ICUs. So there are states that are moving in that direction as well. So.
And actually, it goes both ways because I was a nurse practitioner in the burn center for a little while, and we had pediatric patients in our burn center, and my supervising physician was very, very strict that I don't have anything to do with them, which is the safest thing for the patient.
Absolutely.
You, sir?
So, hi, thanks very much. Greg Martin from Emory University. So I just wanted to echo a lot of what I've heard, which is there's often a big gap between where people finish training and when they're competent or ready to start practicing in the ICU. And to this point about whether it's legality or whether it's clinical competence, it's one of the things we recognized at Emory, and to the point that we were doing the same thing in terms of building out the workforce, and we actually started a post completion of training program where we would actually train them in critical care, which is generally a 12-month program. And it was all about that. It was about taking people and making sure that when they were actually done with that training, that they would be ready to be independent practitioners. And for us, it's an interprofessional program. So we train NPs and PAs side by side in that program so that we recognize that that's the model that they'll likely be working in. But it does help to address this question. And I think for a lot of people, it helps bridge that gap as well.
Yeah, I mean, I would say I don't think that there may be a few, because I know there are some acute care NP programs out there that are more, you can take a critical care track, but I would say most NPs and PAs are not gonna come out of school ready to work day one in your ICU, hence the purpose of us all being up here and being so passionate about it. But you can get them there if you give them enough time, give them the resources they need, and I promise you it will be worth it. But that's what this is all about. You're right, you gotta get them up there.
The other thing, in particular with that, is that even if somebody comes out, for instance, as an FNP, but does one of those postgraduate programs, it still doesn't change their certification. So that's important to go back and be sure that they are definitely whoever's, if they're practicing in critical care, that they do have the matching certification with that.
Hi, my name is Nimesh Shah from Washington, D.C. So one of the problems that I have is integrating trainees, residents, and fellows with APPs. And it's very easy for them to get siloed within their sort of sub areas.
Yep.
And how to integrate the team. Particularly one point you said is leaving the egos away, what's best for the patient, right?
Yeah.
And so how do you balance that? And number two, the APPs are generally better clinicians because they've had the experience, but to the detriment of the education of the trainees. And so a lot of times our feedback is that the education is no longer as good as it used to be because of the APP presence. How do you balance all that?
Are your NPs and PAs mixed in with the fellows in residence?
Yes.
Are they two separate? They're mixed in?
No, they're all integrated into one team.
One team?
Yep.
Yep, okay. So, yeah, go. You can come up here if you want.
So they're all, at least the way we have it set up, they're all on one team, or we have two ICU teams, and they're PAs or MPs on both teams with the trainees. But to not affect the resident fellow training, if the NP is following the patient, of course, it's their patient. They get first dibs on all procedures. If the resident or fellows following the patients, the fellows kind of follow all of them, so that's a little different. They get the first dibs on all the procedures for that patient, because we want everybody to take ownership for their individual patients. The attending's there to support them. The fellows kind of there helping with oversight. But for the residents, there was a big concern that we had when we first started using MPs in our unit. Oh, they're going to take all of our procedures. That was the big thing that they were worried about. We won't get our training. But not so. They have a right to. If they're following that patient and writing the notes on that patient every day, they should be the ones to do the procedure. And the good thing is trying to create that relationship. If we've got an MP who is intubated 200 times, more than likely he or she is going to say, you know, I'll give it to the intern if they want to do it because we know they need that experience too. But it takes a lot of work and effort to get there. It won't happen overnight. It continues. It happens by continually reminding everybody that it's a group, it's a team, and that everybody's here to get the best learning and provide the best patient care.
Agree with all that, but one component of that team is the nurse. And we find that the nurse subverts the residents because they know the APP is there,
Yep.
and they go behind their back because they got an experienced clinician.
We can't help that we're also nurses like this. So, but I think that's universal, and we used to have that. We used to have the reverse problem, like the nurses would always go to the fellows, and now they're always coming to us because we're always available. But I think that's really, you have to get into the nurses side of things for that. The other suggestion I would have for you is have your NPs and PAs teach. So they don't feel like they're missing out that education or the education's not being given because the nurse practitioner already knows how to do it. Make that person then teach them if it's an academic institution. And then I promise you it will turn around and your residents will be excited to have those providers on that team.
Hi, thanks. Bob Baton, I'm a PA from Atlanta. I've actually work at Emory per diem and indirectly help with their postgraduate residency training, but I work across the street at Piedmont, which is a community hospital on steroids. And their case mix index actually higher than Emory's main campus. That said, we have a postgraduate residency program in cardiac critical care. The challenge I've noticed is, you know, how do you standardize this, and maybe CHEST is a forum to do that, just to have each program doing the same thing. You know, are you doing it based on ACGME? You know, we modeled ours after COCATS 4, which was a cardiac one. But how do you deliver that, and what kind of metrics are you choosing, and how do you ensure at the end of the day that you're delivering someone that's finished a postgraduate residency?
That's tough.
I'll tell you this, one thing we've been discussing is that we're going to recommend it, that CHEST actually set some guidelines. We set a lot of rules for training people. That's one of the things that we're going to work on to get some recommendations.
I think there's a new session starting, so we'll answer this one last question. If anyone else has questions, we can meet you outside.
I'll be really
time.
fast. 'Cause
Yeah.
he actually asked one of my questions about APPs and fellows training together. We have that power struggle. I'm in Louisville, Kentucky. We have that struggle at home. It's really, really bad there. And it's attending driven.
Oh,
That's
okay.
why it's bad. Secondly, the other problem we have in Kentucky, and this is a Kentucky Board of Nursing problem, is that the nursing, I guess the acute care nurse practitioner programs are requiring students to perform clinicals with APPs instead of physicians, which I think is not the route to go. As a physician, if you were in training, you would do your cardiology rotation with the cardiologist, you'd do your pulmonary rotation with the pulmonologist, you'd learn your procedures from someone who is an expert in the field.
Yeah.
I don't know how it's done other places. And I also like to remind people that acute care is not just ICU, it's hospital.
Yep.
And I think a lot of students, nurse practitioner students in particular, don't understand that. They only want to be in the ICU. Well, everybody wants to be in the
It's
ICU.
not. It's like
but it is acute.
hospitalist-based
Yeah,
medicine.
it is
Yeah.
hospital. And we have the same problem, family. I'm family and acute care boarded. So, but we have that problem. Family NPs think, oh, I'll get my nurse practitioner, you know, I'll sit for my boards and then I'll go work in a hospital. And there's no control of that. They go wherever they can get a job, in Kentucky anyway.
Yeah.
So anyway,
Yeah.
I just wondered if you had anything to say about the training from a nurse practitioner to, or an APP to an APP. Do you also make sure that physicians are involved? Because, you know, we really strive for collaboration between the two groups.
In Iowa, it's just if you can find a preceptor, like you're real lucky. So I think limiting it just to APPs, I don't know if your question is more about will their education not be strong enough, or will they not be able to find enough?
No, I think it's
preceptors?
important that we have both. I don't
Yeah.
think it should be one
I
or
would
the
agree.
other, because I think the scope of practice is completely different, but you need the influence of both. But I would want my specialist training from a specialist.
Yeah.
And not be with an NP or a PA just because that's what was required.
Right.
None of us went to medical school. It's very different.
Yeah.
And and I could say the same for physicians, their training is very different. We have things to offer that they can't because of our kind of training that we have. So that's a huge issue in Kentucky. So I just wondered if anybody saw it anywhere else.
Yeah. Let's take this outside.
And so, like, the way I take a lot of business students just recently, I'm a PA student, and I'm very much on, like, we have a group of 11 positions. When it comes to, like, ventilator distribution, all of that, all of my comments are in and I start everybody with my patients. I want to learn how the physicians are, okay, I'm on here, so what does it mean if I take a picture, or what do you not want to, you know, okay. Yeah, I saw I'm in and so the finding students, even though they say I'm doing all the hours with you, well, they're exact also hours with you. And so I always know it's on my girls. I tell you so.
How do we go? I don't have a token. I don't know what's going on here. And Teresa just stepped out. We'll have to. radio.
Focus.
Just yesterday, we tweeted this, and it's actually being live streamed on Facebook. And I said, here's the thing, if you want to watch it, text me or stream it. It's on Google this time.
So you're going to be his talk and then you were talking?
His talk. So I will finish that in 30 minutes. And take a little bit of time. It says, give me minutes and
Are you going to do both back to back, or are you going to pause and take questions for this talk?
Have you got
213 is good to go.
All right, thank you.
213 looks good to go.
Good luck.
Thank you. Okay, guys, I'm ready to go. If you guys are ready, everybody ready out there? We have people. This is kind of a cool thing with social media today. We are both live streaming to Facebook and live tweeting to Twitter in this session, so this should be fun. My name is Steve Simpson. I'm the overall moderator. I'm also giving a lecture in which I'm going to channel Chris Seymour, and then I'm going to give a talk in which I channel myself, and that should be fun. So welcome to those of you who are on the Facebook live stream. Thanks for joining us from wherever you are. Chris just could not be with us today, but he was willing to let us have some slides from a talk that he recently gave in Europe. And so we have 3 topics. And so it doesn't show that on your program because Chris had to turn down his invitation. But this was originally conceived as an opportunity to talk about QSOFA, an opportunity to talk about SIRS, and an opportunity to talk about machine learning approaches, all for the diagnosis of sepsis. And so that's what we're going to do. And again, I'm going to start off by trying to channel Chris because I felt like that was the easiest place for me to start. And so this was the talk that Chris would have given could he have been here. Since I'm doing it, these are my disclosures. I have funding from Kansas City Area Life Sciences Institute, and I am a section head for Surviving Sepsis Campaign. Additionally, I'm going to very quickly put on a different hat and let you know that our United States federal government has taken a very strong interest in sepsis. I have taken a 50% position as a senior advisor to this program that you see listed here named Solving Sepsis. Solving Sepsis comes under HHS, under ASPR and BARDA, which are basically exist to protect us from such threats as influenza pandemics, chemical, radiological, and biological warfare instruments, and they realize that all of those things lead to sepsis and that the U.S. needs to be better at dealing with sepsis if we're going to defend ourselves against those threats. So they view sepsis as a security threat to the nation, and sepsis must be solved, and that's the task that they have given us. So very briefly, I had my government hat on. Now I'm going back to my ACCP and University of Kansas hat. These were Chris's disclosures. This is Chris's agenda, which I'm going to go through because since I'm giving 2 talks, I have to go flying through both of them. So Chris poses this question: why did we think we needed QSOFA, or why did they think they needed QSOFA? They had just defined sepsis as life-threatening organ dysfunction due to a dysregulated host response to infection, and set the criteria based on a change in 2 points of SOFA score. Well, there are multiple ways to get 2 points in SOFA score, and Chris actually does a little calculation here for us, showing that given that we have 6 organ systems, 9 physiologic variables, and a total of 24 points in the SOFA scoring system, how can you get an increase in 2 points? Well, one way is if you get 1 point in any given organ, there are 15 different ways that you can get 2 SOFA points from 6 different organs. Then on top of that, you could get 2 SOFA points in any of the 6 organs, so that's add 6, so they're 21. On top of that, you could have a fair number of 3 points in one organ and 1 point in another, et cetera, et cetera. So there are just a whole lot of ways that you can get 2-point increase in SOFA, and we need something that's a little bit easier to deal with. Conceptually, what would you want? You might want something that, as Chris says, it's different, it's not better, but some of the things you might want are low cost. You'd want it to be quick, easy to use. You'd want it to be reliable. You'd want it to be repeatable. And you'd want it to have acceptable validity. And he gives a little map of different types of validity, but you might want something like this: low cost, quick, reliable, repeatable, for the most part, except in New York City maybe, and acceptably valid. So that's what they went looking for in the data. What did they look for? Well, they didn't go looking amongst all patients presenting to the hospital with a bazillion different variables. Actually, this is more Matt's bailiwick. But they did not do this. All patients presenting, looking through all the variables that might show that patients had developed or would develop sepsis 3, or in this case, look for the outcome they were looking for. Now, you'll remember in the sepsis 3 discoveries that they were looking for mortality or an ICU length of stay of 3 or more days. So this is not what they tried to do. It narrows the spectrum a lot if you narrow it down to people who are suspected of infection already, and then look for variables that might portend the outcome. And so you have a lot less complex thing to do here. And so what they did do was a multiple logistic regression model looking for the variables that had the biggest impact on outcome, and I think you're probably all well-versed in what they did find, which was that the variables of interest that come out of the model are altered mentation, that means a GCS less than 15, You may remember they started with a GCS less than 13, but found that adjustment to anything less than 15 didn't substantially alter the prediction or predictive ability of the model. Elevated respiratory rate, in this case 22 or more, and systolic hypotension, which they define or which they found at a systolic blood pressure of 100 or less. So those are the QSOFA variables. So as Chris says in his slides here, that really seems like a prompt to clinicians just to remember some things that they probably either already knew or should have already known. So these things are obviously easy to use at the bedside. You can tell whether someone's altered, you can count their respiratory rate, you can measure their blood pressure. It doesn't take any special tests to come up with, does a person meet the variables of this model? QSOFA definitely risk stratifies, and what he has shown here, first on the left, is the SOFA score itself, for which there's more perhaps robust data, and what you see is the mortality here on the y-axis, the SOFA score across the x-axis. This is the actual mortality with confidence intervals around it, and then this represents the number of people who meet, or the proportion of people who meet any given SOFA score. So clearly SOFA score, and we've known that for quite some time, that SOFA score has good risk stratification for mortality. So basically what Chris has displayed here is the same thing on this graph, only this is for the QSOFA score. And so of course this QSOFA score only has 4 possible outcomes, 0, 1, 2, or 3. Again, this is the proportion of people in their study that met any given QSOFA score, and this is the mortality. So that as QSOFA score goes up, mortality also goes up. Oh, I guess I forgot that was coming. So it also has predictive validity, and what do we mean by predictive validity? We are interested in a test that when it's positive, the patient's highly likely to have the disease of interest, and when it's negative, they are more likely not to have the disease of interest. And that's defined by the area under a receiver operator characteristic curve. And so you can find this in the JAMA article as well. And what Chris is showing here is comparisons of all the different scores to one another. But across the diagonal line here, the QSOFA and the load score showed the greatest predictive validity or predictive ability for mortality or prolonged ICU stay among patients who were not residing in the intensive care unit at the time. And of course, the reason QSOFA bubbles out is that it can be, as we said, quick, done at the bedside, doesn't require any laboratory tests, and that makes it more of a more ideal test. It's not an ideal test, but it's more ideal than the load score, even though they had the same area under the ROC curve. So since then, there have been multiple validation studies, and as Chris says, the original paper has been cited 336 times, which is quite a substantial amount for 2 years. There have been at least 38 separate papers comparing QSOFA to SIRS for this purpose. The performance is variable in all of these studies for both risk stratification and for predictive validity. But no one really, as he says, sought to tackle the conceptual underpinnings. No one really delved into is mortality the best thing to look for? Is organ dysfunction the best thing to look for? Most of these have just simply been repeat comparisons of QSOFA versus SIRS. What's new with QSOFA? This has actually been published just last month in Critical Care Medicine. The QSOFA is not a one-time measure, or doesn't appear that it needs to be used as a one-time measure for diagnosis. Can be measured all the time. And what they are displaying here is 6-hour epochs after suspected infection with a heat map of how this can look amongst people who die versus people who don't. You see the more pink and red that appears, the more QSOFA points appear in any given epoch. And I think the bottom line comes from this, that there are trajectories of QSOFA that are even more predictive for mortality than the one-time measure. Such that if you start with a high QSOFA and you maintain a high QSOFA, you have the highest in-hospital mortality, above 40%. If you start with a low QSOFA and maintain a low QSOFA, you have very low in-hospital mortality. And then you can see there are moderate QSOFAs, or there is you begin very low, but you increase the number of epochs and higher degrees of QSOFA, and that gives you a moderate risk prediction. So that's again, that was published in Critical Care Medicine just in September. Finally, QSOFA has been studied in low and middle income countries, which is, I'm sure this was spurred, as you know, there are a lot of people in low and middle income countries said we can't use this new sepsis diagnostic algorithm because there are things that we just don't have. And so they've looked at QSOFA in low and middle income countries. This data I have not seen except in Chris's presentation here, been studied in these countries, been studied in various different conditions, which I find fascinating, including melioidosis, malaria, dengue, and pneumonia. And basically what they see is that again, this is the map histogram of the proportion of encounters at a given QSOFA score. The same with SIRS here on the left. And there's a risk stratification that comes out even in low and middle income countries from this data. So it indicates that being easy to use and free helps when you live in a country where you really don't have the money or the capacity to send rapid tests to the lab. So what is QSOFA? Is it a prompt with some predictive validity for sepsis, i.e. it finds out who does badly among infected patients? It does not require blood tests. It does risk stratify, although as Chris says here, you could probably develop a better risk stratifier, but nevertheless, it does stratify, and it isn't yet known whether the use changes outcomes at all. I would say questions, but I think what we're going to do is hold questions on this one until after, at least after this talk, possibly, yeah, at least until the end of this talk. So now to the portion that is advertised in the program, and this is the part that I'm to give. Is SIRS truly not useful? So one of the things that struck me when I initially read the third consensus conference was this particular statement, that the current use of 2 or more SIRS criteria to identify sepsis was unanimously considered by the task force to be unhelpful. And if they had said it was unanimously considered to be flawed, I would have taken that, would have understood. But to be unhelpful bothered me personally a little bit. And let me see if I can illustrate why it bothered me personally a little bit. Here, this is a recent lesion that I encountered, took a photo of. I'm not sure how well it shows, but in addition to this road rash here, there is some pink cellulitis developing around the perimeter of this lesion, which made it a little bit concerning. Now, so this is just, I should have set this up as a poll, but I didn't. So if these were the vital signs in this patient, what would you do? Not much of anything. You'd put maybe some antibiotic ointment on it. You'd keep it covered so it doesn't get any worse infected if possible. And you'd say, go on about your business. So let me just ask everybody in the room, if these were the vital signs associated with this lesion, what would you do then? Would you still just cover it up and put some antibiotic ointment on? Or would you perhaps give antibiotics and or judge whether any fluids were necessary based on the patient's presentation? See, I think that it's highly likely that you would do the latter. I should have people raise hands, but I'm not going to do that. Now that I've told you what I think the answer is, it wouldn't be fair, would it? So why, when you looked at that, why did you think I want to do something different? And I'll tell you why. It's because you recognize that the latter circumstance, which is infection with systemic manifestations, or SIRS, is something more than just a simple localized infection. And you're not the first people who would have thought that. In fact, Hippocrates said this: a local lesion heated by humor efflux makes the whole body become feverish. One can die because of this. And then this is the good part, especially on odd-numbered days. To his credit, Hippocrates was the first to try and use empirical observation rather than this is something the gods are giving to us. He did think it was abnormal humors, but nevertheless, I just want to point out to everybody that today is an odd-numbered day, so you may want to be careful. So, defining sepsis, as we said, life-threatening organ dysfunction due to a dysregulated host response to infection. I just want to look at this. This is a quote that hit me sometime during the past year, that Bertrand Russell, being a philosopher, was literally talking about everything when he says everything is vague to a degree you don't realize until you've tried to make it precise. And this is an issue that we face in diagnosing sepsis. So I hope to conceptualize it with this little map here. So what this glob represents is activation of white cells, production of cytokines, production of adhesion molecules, vascular permeability, increased cardiac output, what one might see in the infected state. I've labeled it infection with SIRS, but the label could be anything. As this condition progresses, if it isn't treated, there becomes more activation of all of these things. Perhaps there becomes organ dysfunction because of these things. And then as it continues to progress, it develops hypotension and possibly elevated lactate. So that we've developed into septic shock. Now you'll notice that this is not Venn diagrams. On purpose, this is not Venn diagrams because a patient is not a Venn diagram. This condition progresses irregularly, as we say in our definition, in a dysregulated fashion. Whether I can't recognize dysregulated, but I know that it happens somewhere in here. So the problem we're faced when we're trying to diagnose people with sepsis is we are essentially drawing a line here and saying, if you're to the right of this line, this is bad. This is, I don't care whether this is infection with 2 SIRS criteria, infection with Q-SOFA. We're saying if you're to the right of this line that represents something that's rather difficult to wrap our minds around, that's bad. If you're to the right of this line, it's even worse. But then the question is this the right place to draw the line? Or maybe that's the place. Or maybe that's the place. And how do we tell, given that this isn't really a series of stepwise progressions, this is a smooth flowing object that flows from not so bad to really bad, not in stepwise gradations, but sort of rather smoothly. So that's what we're trying to do. So now this is Roger Bone, who was the first person who tried to take that and draw some lines. Previous to Roger Bone, look how people in the 1970s defined sepsis for the purposes of testing whether corticosteroids at high doses would alter the course of sepsis. Positive blood cultures, multiple positive blood cultures plus hypotension. You know, of course, it was hard if you use these kind of different definitions, how are we going to find a consistent answer? And they didn't. And so Roger developed a definition and applied it. And what I'm going to take just a few seconds to say, because this always is fun for me, is when Roger developed his particular criteria, he was an assistant professor at that university right there, the University of Kansas, where I work. So brief advertisement, forgive me. Maybe that's my conflict of interest. So I want to talk about some things. I labeled it misconceptions about SIRS. Maybe they're not necessarily misconceptions. It could be just some things that have been said about SIRS and its weaknesses. And the three that we're going to focus on here are the emphasis has shifted from inflammation to organ dysfunction. Requiring SIRS to diagnose sepsis misses cases of infection-induced organ dysfunction. And SIRS isn't specific to sepsis. People will say things like this: I climb a set of stairs and I get SIRS. Okay, so let's talk about those. Emphasis has shifted. Really, that's not true. It just plain isn't true. What I'm about to show you is the first description of the sepsis syndrome by Roger Bone, published in 1989. And I just printed an excerpt from it because I want to show you what Roger emphasized. So, yes, was SIRS included? What we now know as SIRS? Yes, it was included, as was clinical evidence of an infection site and what? Inadequate organ perfusion or dysfunction. So this whole thing began with the notion that inadequate organ perfusion or dysfunction is the key bad actor. This is what kills people. And so really, we have not shifted emphasis. I think the shift in emphasis came as much as anything because of the first ACCP-SCCM consensus conference on definitions of sepsis and organ failure. And what happened was that at that conference, in order to achieve consensus, infection with SIRS was separated out from infection with SIRS and organ dysfunction, and then sepsis and hypotension. So some of the people at that first conference are still around. Several of them are, but I happen to be in email conversation with Charlie Sprung, and what Charlie told me about this: why did you do this? Why is this the way you proceeded? The original consensus conference was set up for several purposes. Among others, one was for uniform definitions, and another was to try and diagnose septic patients who were being missed, if possible, at the earliest possible stage. And that's why they separated out infection and SIRS, in hopes that if you intervene at that level, you don't get to the more severe levels. Oh, I guess that's what I said here. It was intended to prompt physicians to look for organ dysfunction. Requiring SIRS to diagnose sepsis misses cases of infection-induced organ dysfunction. And a lot of that arises from this particular study that comes from the Australia and New Zealand Intensive Care Society, published in 2015. And what did they find? And it was rather interesting to me. The spin that was put on it was, well, the sensitivity of 2 SIRS for organ dysfunction is only 87.9%. And so it depends on whether you're a glass half full or a glass half empty person, I think, when you look at this. I go, what other screening do we have that hits 88% for sensitivity? That's really not all that bad. But what they were trying to say is it misses a fair number of people in this rather large study. I do just want to point out a couple of things, though, about SIRS that were also in this paper, and that is the presence of SIRS with infection-induced organ dysfunction increased the mortality uniformly. And what this graph is showing is that across the years from 1999 to 2013, that mortality was decreasing in Australia and New Zealand, which is good, but that having SIRS be positive increased the mortality rate across the board. Also, SIRS itself can be a risk stratifier, as they showed in this study, that the more SIRS criteria you meet, the higher the mortality. Notice the mortality never goes quite as high as what Chris showed us in his slides. But they do make an interesting point that I thought was interesting, which was that really, if you look here, this is an almost linear climb from 1 to 2 to 3 to 4 SIRS. And there's nothing special about that demarcation of 2. At least that's the way they write in the discussion. I think one might make a case that at 2 there is likely a statistically significant difference from 0, and perhaps it works out that way. But nevertheless, SIRS does have some predictive validity for, not validity, some predictive ability for mortality, or it does risk stratify. So there have been several things comparing SIRS to QSOFA. There are now 4 meta-analyses in the literature of 38, at least 38 different papers, and they all seem to come down about the same way, which is if you're looking for a mortality predictor, clearly QSOFA is favored. If you're looking to predict sepsis, SIRS is favored, and this is from this one that was published in CHEST. So SIRS was superior to QSOFA for sepsis diagnosis, and QSOFA was slightly better than SIRS for predicting mortality. Okay, fair enough. Requiring SIRS to diagnose sepsis misses cases of infection-induced organ dysfunction. Agreed. It does. About 12% of them. But my point is, none of us in this room probably ever relied on whether SIRS was present or not if we saw infection-induced organ dysfunction. I certainly don't. I bet that you don't either. When you see that, you treat as a serious situation. So it's not specific to sepsis. I climb a set of stairs and I get SIRS. Again, I'm not going to make any argument about that. It is clearly indisputably true. However, there's something that I think people are forgetting. First off, I want to go back to Roger Bone's initial definition. Clinical evidence of an infection site. That wording, as you all know, changed with the consensus conference to known or suspected infection, and I think we did ourselves a disservice with that. The way that Roger states it, you got to pretty well know that your patient's infected before you're going to call them septic. The way that SIRS developed over the years is, oh, if I've got a fever, I'm clearly infected, therefore I have a suspected infection, and now I've got SIRS and suspected infection, and it became a circular argument. There is no doubt in my mind that that has happened. However, I want you to not forget this thing, Bayes' theorem. And I know that you already have, and you will as soon as I get off the slide. But the key thing about Bayes' theorem is that it says if your test is positive, the likelihood of having the disease of interest depends on these things, one of which is the probability of the test being positive in the group you're looking at. Okay, so what would that mean with regards to sepsis? The probability of sepsis when you have SIRS is roughly equivalent to the probability of SIRS when you have sepsis, and we know now that that's about 88%, times the probability of sepsis in the group that you're looking at. Now, if you're looking at people climbing sets of stairs, that probability is going to be exceedingly low. If you're looking at a person who has a cough with purulent sputum, pleuritic chest pain, and consolidation in their chest, that probability gets substantially higher. So the point is the group you're looking at and how you're looking at them, knowing a clinical site of infection makes a big difference in how one interprets the presence of SIRS. SIRS, again, does add mortality information. We already saw that from the ANZIX data. We've known that since 1995. This is data from the University of Iowa. These are just patients, mostly surgical patients, that just the presence of SIRS. The presence of SIRS was associated with increased mortality. Sepsis itself, severe sepsis, septic shock. So we've known that for a long time. These are data from Chris's study for the sepsis 3 showing the same thing. This is in ICU, SIRS, QSOFA, SIRS and QSOFA outside of the ICU. So we know that both of these can risk stratify. Of course, the weakness of SIRS, we all understand, is that it is so highly sensitive that it is less specific, and that's what we all get. However, this is an important piece of information. You recognize this, Dr. Cherpak? This is from data that Matt presented in the Blue Journal. And there's something that's of importance here when you are looking at this from the standpoint of early diagnosis of patients. And that is, if we draw the 50th percentile line here, what we see is that SIRS, the median time before the event in question, and in this case it was ICU transfer or death, the median time that SIRS is present is 17 hours before that occurs. The median time that QSOFA is present before that occurs, on the other hand, is 5. And in fact, if you look at this, you can see that just under half of people who met that endpoint never had QSOFA at all. And then the fascinating thing to me, Matt in his paper looked at the National Early Warning Score from Great Britain and found that it sort of split the difference. And the fascinating thing is if you know about news and the components that are in it, you recognize that it is almost a hybrid of QSOFA and SIRS. Just fascinating piece of data. So I'm going to tie this up by saying, so how do we proceed with SIRS and with QSOFA? And I think the bottom line turns out to be really relatively simple. So you got to look for the infection. You got to have a good reason to believe that there's an infection. I like the way Roger said it, site of infection. I recognize that there are a lot of people we take care of these days that, say, have indwelling long-term catheters for cancer chemotherapy. Maybe all they get is bloodstream infection. That makes it a little more difficult. But in general, look for the infection and know what you think the infection is. If you see infection and SIRS, what do you need to do? Treat them. Look for organ dysfunction. If you see infection in QSOFA, what do you need to do? Treat them and look for organ dysfunction. Perhaps treat them even faster because the time until the outcome of interest may be shorter. That's it. That's what I have to say. I'm glad to take a couple of, actually, you know what? Why don't we let Matt give his talk, and then Matt and I will both take questions, and that's the way this was set up. We originally intended a panel with Chris, Matt, and myself, but we'll let Matt talk, and then we will take some questions.
Hello, everyone, and thank you, Steve, for inviting me to do this talk. I'm really excited to talk with everyone today. So I'm going to approach this from a bit of a different perspective, both on how we think about sepsis, and also I'm going to touch on what I think potentially the future of sepsis could be in the hospitals today. First, my funding is shown here. We do have a patent pending for the risk stratification algorithms that I'm going to talk about today, but I have no relevant commercial interests. So as Dr. Simpson discussed, we now, with the new definitions, define sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. So essentially what this new definition is saying is you're essentially looking at patients who are infected and looking at patients who are critically ill, and sepsis is really the combination of those two things. So from my perspective then, when you're thinking about sepsis, these are actually two different prediction problems. I want to know if someone potentially could be infected, because if they're infected, then I'm going to give them early antibiotics. I'm going to look for things like source control, try to identify the site, take out the central line. I'm going to focus on treating their infection. At the same time, when I think about critical illness, if someone is potentially likely to become critically ill, I want to consider getting them to the ICU sooner, consider things like vasopressors or fluids, and also consider things like family discussions for those patients. So I'm really going to try to, in this talk, disentangle the infection piece from the critical illness piece. So as Dr. Simpson nicely outlined here, when you think about SIRS and QSOFA and combine the data that's out there now, it's really about a higher sensitivity test versus a higher specificity test. In this review from Annals of Internal Medicine from earlier this year, outside the ICU, SIRS had over 80% sensitivity, but specificity in the low 30s. Whereas QSOFA is less sensitive, only about a 50% sensitivity for things like prolonged ICU transfer or death, but is much more specific with a pooled specificity of around 80%. So which tool you use really depends on what your goals are. And of course, as I think many have talked about, there are problems potentially with both SIRS and QSOFA. I think one of the main issues with SIRS is that if you look around the hospital, so many of our patients have it. Over 90% of patients in the ICU will develop SIRS at least once during their stay. Over 60% of post-op patients will develop it. And if you look at patients on the wards, and this is from our data from a few years ago, if you look at the time on the wards along the x-axis and the proportion of patients meeting SIRS criteria along the y-axis, you can see that by the time patients are in the hospital for 2, 3, 4 days, most of those patients are going to have developed SIRS. So if you imagine many of us are now at hospitals that have electronic health records, I would ask you who in the room really wants to be holding the SIRS pager every time a pager goes off and seeing that alert in their EHR? Because it just went off. It's going off again, and it's going off again, right? It's unfortunately, especially when we try to automate systems like this is what many hospitals have seen when they've tried to automate this. Again, because of the fact that if you just look at SIRS on its own without this idea of like, are you actually infected as well, you're going to see many, many alerts in these patients. However, as Dr. Simpson and I say outlined, there are several problems with QSOFA. The sensitivity is unfortunately too low, especially earlier on in a patient's course. And if you finally then wait till someone has 2 or more QSOFA, it's going to be too late for early recognition. You're only going to be a couple hours before your ICU transfer or mortality. In addition, in my mind, QSOFA is also too simple. I think one of the other criteria we should think about when we have risk scores we want to implement in practice does it actually do better than we do in our own clinical intuition? Because I think when we think about things like if a patient has altered mental status and hypotension, I think most of us in the room would agree that that patient is sick. So I think in this day and age where companies around us are like grabbing all of our search terms and all of our data and everything they can to make incredibly complicated tools, I think honing it down to just 2 or 3 variables I think is just too simple, and I think we should do more than that. So what about early warning scores? Well, since the 80s and 90s, there has been another movement going along, which is the rapid response movement, which developed things called early warning scores. And these early warning scores developed from earlier literature showing that patients who suffer cardiac arrest in the hospital often had vital sign abnormalities hours and hours and sometimes days before the event. For example, in this study by Hillman and colleagues, they looked at cardiac arrests that occurred on the ward, and between 0 and 8 hours before the event, about half of patients had vital sign abnormalities. But if you look earlier, 8 to 48 hours, still about half of these patients had vital sign abnormalities. So these deterioration events that occur on the hospital wards are not sudden like out-of-hospital cardiac arrests. They're typically deteriorations that occur over many hours and sometimes days. In addition, if you look at what happens when patients become critically ill in the hospital and suffer cardiac arrest, there are many important errors that occur, such as delays in diagnoses and errors in diagnoses. And often the resident or trainee house officer is the only person who's seeing these patients in the hours before the event. These data and these concepts over the course of decades now have led to the development of rapid response teams and the mandating of these systems across our country as well as many countries across the world. So the thought process then is for early detection, of course, many of our patients are admitted, they're sick, and most of them get better. But some of the patients start having deterioration in their physiologic state. And of course, we have the intensive care unit there for us to help get the patients there when they need the ICU. But importantly, rapid response teams are supposed to move this earlier so that you're detecting critical illness earlier and potentially preventing the critical illness event from happening and also decreasing mortality. And so early warning scores then, over the course of time, have become an integral part of these rapid response systems where patients deteriorate, the decline is recognized, and the RT is activated. And recognition of clinical deterioration is done both by the bedside clinicians, but also by these objective scores that have been developed. Now, the first objective scores were developed, again, in the late 90s. And this is one example that was used in the multi-center merit study published in The Lancet almost 15 years ago now, which were simple single criteria. If a patient met any of these criteria, you would call your rapid response team. Now, more accurate scores have been developed since these criteria. This is called the Muse score, which you have different vital signs as shown here in the rows, and then you calculate a Muse score based on how sick your patient is. And in fact, in academic hospitals in the US, there's some data that suggests this is the most commonly used score the hospitals are using for the rapid response team, in part because these are now automatically calculated in your EHR in several of the more common vendors. The News is another early warning score, which essentially was adapted from the Muse, was improved upon based on patient-level data, and then they also added oxygen delivery information to further improve the accuracy of the score. So one of the things we wanted to do once we saw QSOFA was to say, well, hospitals today around, in our country and countries around the world are already using things like Muse and News for risk stratification. What if we just applied these to infected patients? How well would it do against QSOFA and SIRS? And so in a study we published in the Blue Journal 2 years ago, what we found was if you look at the area under the curve along the x-axis, you can see whether you're in the emergency room or whether you're in the ward, the News is significantly more accurate for predicting mortality or need for ICU transfer than QSOFA or than SIRS. So again, a score that hospitals are already using could be used to potentially predict outcomes and risk stratify patients with infection. And again, as Dr. Simpson mentioned, timing matters. So as mentioned, the News criteria shown here can certainly identify patients earlier on in their course. And if the nice thing about News is that there's many different thresholds. You didn't have to pick a score of 7. If you want greater sensitivity, you can lower your score if you want earlier recognition. So there's also, you can match what score you use, the threshold, to the resources available at your hospital. So it's not just a one-size-fits-all tool. In addition, as was mentioned earlier, News actually incorporates QSOFA, and it also incorporates SIRS, and then it incorporates many more things. So again, if you think about this, the fact that humans are said to be able to hold 7 pieces of information and integrate different, just different aspects of information and have trouble beyond that, once you start adding these, going to these more accurate scores and more complex scores, you're potentially starting to get to the area where we may be able to actually add value to clinician intuition. Now, as I mentioned before, these scores can be calculated accurately and instantaneously in the EHR, and now many hospitals in the US are now using electronic health records to the point where they can actually do this. But I would argue that running a paper-based tool that my 7-year-old can easily calculate by hand is sort of like having a Lamborghini but only being able to drive it around in a traffic jam. You really want to get it out there. You really want to see what can this computer actually do. It can do a lot more than just calculate a hand-based tool. And so what I want to focus the rest of the talk on today is to talk about this revolution of big data and machine learning and how it could potentially be applied to sepsis. So first, what is big data? Well, big data is been described by many, including IBM, as data that comes in at high volume, high variety, high velocity, and also the veracity of some of the data is uncertain. And I'll just point you to some of my residents and other people's notes to understand that a lot of different terminology is used, and sometimes the data is uncertain. So I would say that what we see in the EHR really is big data when you combine labs and medications and notes and images and everything that's there. And how do other industries learn from big data? Well, clearly companies like Amazon and Netflix, and I can't even believe to say it, but the United States Postal Service is actually using machine learning to try to improve where the mail goes, which living in Chicago still doesn't work very well, but is maybe better than it would be without it. And of course, companies like Google are trying to make us, make us feel bad because we're no longer the kings of games like chess and Go anymore. And what they're using is they're taking all the data they have available to them and putting them through modern, powerful machine learning algorithms to try to improve prediction, which then helps them take better care of their customers. So one of the things we wanted to do for risk stratification was just to say, okay, well, let's think about what can these other more modern algorithms do compared to what we use in medicine all the time, things like logistic regression. So when we compared these different algorithms in a data set of over 269,000 ward admissions for predicting which patients go on to die or suffer a cardiac arrest or go to the ICU, we found that modern machine learning methods were significantly more accurate. You can see the logistic regression with linear terms that gives you odds ratios that we love to see in papers is actually the least accurate of all the different algorithms for risk stratification and identifying early critical illness. So upon seeing that, we wanted to ask the next question, which was, well, why are these patients deteriorating? What clinical condition is driving the deterioration? So we just finished a chart review of 800 patients, and what we found was, guess what? Guess what the most common reason for deterioration is? It's sepsis. So given that, the fact that sepsis was so common as a reason for deterioration, we wanted to again see, well, how does this general random forest algorithm that we ran in all patients, how does that work for patients who are infected? So we looked at patients who had blood cultures and antibiotic orders, and what did we find? Just as before, these general risk algorithms that we can use in the hospital for every patient and activate rapid response teams are also good predictors of adverse events in patients with infection as well. So other groups have began to use data in the ICU. The real-time data that we have obviously comes a lot quicker. Tim Buckman and colleagues from Emory looked at developing a machine learning algorithm for sepsis in the ICU using the MIMIC-3 data set as well as their Emory hospitals. And they were able to predict onset of sepsis 3 within 4 to 12 hours, both highly accurately in both their training and in their testing data set. So again, many groups are beginning to do this using their data that they have in the ICU, in the emergency room, on the wards, to improve the accuracy of these risk scores. Because I think that we're never going to find a 2 or 3 vital sign risk score like QSOFA or like SIRS with labs that is going to have the sensitivity and the specificity that we really desire. In order to get there, I think we really need to use more of the data that we already have available to us in the EHR. Now, the other thing I want to talk about today is, I think, something that is often not talked about a lot, which is, we talk about SIRS and QSOFA, and we're always, it's often about risk stratification, mortality. But what about identifying who's infected? Because I think maybe one of the best, if not the best thing that we do for our patients with sepsis is give them antibiotics. And so do clinicians agree on who's infected, I think, is the first question. And I think I already see several people shaking their head no. There's been a few studies on this, one looking at what the emergency room physicians think versus what the doctors think once they get up to the ward. And what they found was that it actually varies quite a bit based on the site of infection. So, if a patient has cellulitis and you can see it, everyone kind of agrees. But for things like bloodstream infection, where you could imagine the mortality can be quite high, the sensitivity of the docs in the ER who are responsible for giving early antibiotics, the sensitivity is actually very low. Now, because of this, groups have also started to develop these objective tools to try to identify infection. And so probably the best well-known and highest cited is the IPS score, the infection probability score, which was developed 15 years ago now. It was developed in one hospital's ICU over 6 months. They used vital signs and labs to predict the presence of infection, which was determined by chart review. They found that CRP and heart rate were actually the most predictive variables of what they looked at. And so here's the IPS score. And as you can see, it actually looks a lot like the SOFA score. And in fact, interestingly, the SOFA score is actually part of the IPS score. So if you want to use the IPS score, you also have to calculate the SOFA score, which makes obviously it very hard to use at the bedside when you're seeing your patients. But I couldn't draw a better ROC curve than this one. I mean, when in the initial study, it was highly, highly accurate. And in fact, when in validation studies within the ICU, it's also been accurate as well. However, as we all know, most of the cases of sepsis that we see are actually first start outside the ICU. And unfortunately, the validation studies outside the ICU have not been nearly as promising. You can see here one study looking at ward patients, the accuracy was not better than a coin flip. And procalcitonin had the highest accuracy in this study. So can big data and machine learning actually help? Can we help with this other problem, which is identifying patients who are infected? And so what we did was we took 1,600 patients at the University of Chicago. We did chart review on these patients to actually identify, were they infected? And the kappa for that was actually greater than 0.8. EHR data then available in the very first 4 hours were used to then predict the onset of whether they actually had an infection during their admission. We used the same random forest classifier I mentioned earlier, just an algorithm that can predict who's infected versus who's not. And when we looked in a separate validation cohort, you can see that the AUCs for SIRS and the IPS score are here, both 0.69. So, in some ways for me, this again suggests that the SIRS have a use. I think SIRS definitely could have a use. If just SIRS alone is this accurate, if you add on your clinical intuition, I mean, this again shows you a place where SIRS could potentially be used. But if you look where the random forest algorithm was, it was significantly more accurate in this initial data set, in the 40% validation data set, as compared to SIRS or IPS. Again, suggesting if we can, and again, this is not a big data set, right? This is only about 1,000 patients who were used for model derivation. So if we can continue to try to scale this, we potentially can significantly improve how we identify infected patients in the hospital. So I think the final thing I want to cover then is, do these automated algorithms actually improve care? Most of the automated algorithms out there are really for the risk stratification piece of this, or actually trying to predict sepsis, or essentially having a SIRS alert in your hospital plus organ dysfunction in your hospital, so you have both criteria need to be met. Several studies have been published in this area which have shown that in general, especially if your rate of antibiotic prescription for these patients is low, it will increase your rate of antibiotic prescription. However, the impact on outcomes has been mixed. If you look at these different studies with mortality on the y-axis, you can see a lot of negative studies or studies with things not moving in the right direction. But if you look at the controlling in blue versus the intervention in red and the studies on the right, those which had the highest mortality, you actually do see a signal that there might be increased outcomes, improved outcomes for those studies. So again, this is potentially for the sicker patients, automating these things, automating identifying infection, automating the risk stratification, might be able to improve outcomes. And again, these are typically smaller studies, and I think there's a lot more that needs to be done. So in conclusion, when you're thinking about identifying and treating sepsis, I really think there's two problems that you need to think about. The first is, are they actually infected? And to identify infection, of course, you want to use your clinical judgment, but you also want to think about using, do they have SIRS criteria, IPS, procalcitonin, and I think one day we'll be using machine learning for this as well. And for those patients, early antibiotics, cultures, and source control are among the many things you want to think about. In addition, on your hospital, you are going to want to identify which patients might need to go to the ICU and identify these patients early. And then for that, you're going to want to use things like your clinical judgment, QSOFA, potentially the news, lactate, and again, I think machine learning is going to become more and more commonly used in hospitals for this as well. For your critically ill patients, you're going to think about things like, do they need to go to the ICU? Do you want to start vasopressors or fluids? And of course, family discussions. And I think most importantly, this should be a bidirectional feedback loop. If you see a patient and you think, you know what, they might be infected, start down that pathway, start the antibiotics, but then the next question you need to ask is, well, do I need to get them to the ICU? Do they need fluids? Do they need pressors? Similarly, when a patient starts having clinical deterioration in front of you, you need to ask the question, could they be infected, and start looking at that as well. So these are things in my mind that are both separate but very highly related for our patients. So I just want to thank my lab and my collaborators and Dr. Simpson and of course Chess for allowing me to talk today, and my family for allowing me to come out here. And thank you all for your attention.
Cool. So we have a few minutes for any questions or comments, and that's what we are here for. If you have one, please tell us who you are and where you're from, and we'll do our best to answer.
My name is Cheng Da. I'm a medicine resident in Michigan. I have a question for Dr. Cherpak. Were you involved in building up any of those machine learning models to predict sepsis?
Sorry, was I involved in what aspect of it?
When building up the model for the machine learning model for sepsis prediction.
Yes, yeah.
can you give me a example about troubleshooting, trying to decrease the false positive or false negative rate of your model? Like one example, what did you do? What did you change to the model?
Right. I think that there's a couple things to think about. I think actually the best thing you can do when you try to automate these processes is the education that you give to the nurses and those who input the vital signs into the EHR about their renewed and increased importance for these things. Because actually one of the first thing that we noticed when we turned the score on was the fact that that it was firing more often due to erroneously entered values. And so sometimes, essentially the issue is that when you look at retrospective data versus prospective data, there's always going to be differences because they recognize these things and then they change it and correct it in real time, but the alert then fires. So I think that's one aspect of it. The second is that these algorithms output a probability. So you in fact have almost an infinite range of thresholds that you can choose. And so you want to develop the most accurate score you possibly can, but then when you think about implementing it in clinical practice, you need to make sure that your threshold is one that matches the resources that your hospital has. So if your hospital has, 3 rapid response team members, 24/7 and can see a lot of calls, you're going to turn the threshold one that you're going to have a lot of activations of the alarm, and that's fine because of your resources. But if you're at another hospital, you only have 1 rapid response team nurse who ends up also being the ICU charge nurse and who has other duties, you're going to want to find a threshold that meets those lower levels of threshold. So not really a modeling answer, but more of a practical answer.
I see. So the different hospital maybe having a different models.
Or either, potentially different models or at least different thresholds for that model, because resources vary quite a bit from hospital to hospital on the implementation side.
Okay. So if I'm interested in machine learning, do you recommend any other training outside of medicine that I need to learn?
Yeah, I'd say there's a lot of training on that aspect of it. I'd happy to talk afterward about some resources that were very valuable to me.
Sure, thank you.
Yeah, but their question is, I think we understand the 2 aspects, right? There's a clinical aspect of using predictive scores and scores for potentially worsening, and then there's machine learning, right? So what they're saying is, you have an intern in the ICU or a resident in the ICU at 12 a.m., right? He calls his fellow and says, I have an incoming transfer or incoming request for ICU transfer from the step-down floor, and the resident on that side is telling us that the QSOFA score is high. And the resident has read that the QSOFA score is not really valid in the ICU. So as of today, when all the models are not applicable, at least in their hospital, and the data is what you presented, what would you, the fellow, tell the resident? Does that make sense? I'm trying to contextualize that question for you.
I think that makes sense. So what you're saying is while he's sitting here on the floor, the QSOFA is high, but when 5 minutes later in the ICU, the QSOFA doesn't matter. So the difference is where's the patient when they develop this score and suspicion of infection, because that's how the study was done. Study was done on patients already in the ICU, and what's the validity of the SOFA, QSOFA, SIRS, and load score, or is the patient sitting in the ICU on the floor at the time that suspicion of infection occurs. So I would say if the resident on the floor has high suspicion of infection and the QSOFA score is 3, they'd better move them to the ICU.
Hi, Jeff Dichter, University of Minnesota. Wonderful talks. Thank you both very much. One of the questions I have is one of the things I was disappointed with SEP 3 was the fact I felt like, I'm an educator, I teach people with sepsis. SIRS got taken away from me and nothing was left in return. So I felt a little, naked at that point in time. But as we had both wonderful talks, I mean, they seem complementary. SIRS has always felt to me to be a recognition tool. QSOFA is clearly evidence that it's a good way of stratifying your patients. Well, can't we keep them both?
Yes.
Yes, I would. I mean, I think when you think about if you want a screening tool, you want a high sensitivity tool that gets these patients early. And we know early antibiotics, I think most would agree that early antibiotics matter. So if that's what you're trying to do, then that's what you need to do, a high sensitivity tool. But if you're deciding who needs to go to the ICU, you're going to want to use the best risk stratifier that you have. So I think, again, it's this idea of what do you want the tool to be used for.
Thank you. And one more. Yeah, go ahead.
Hey, Arun Kanathan, I'm from University of Colorado. The whole machine learning thing it makes me geek out real hard, but I don't know what I'm geeking out about because it's kind of like this black box of science words, and I'm assuming that you have a whole bunch of variables and you say, hey, computer, go, figure out what's most predictive in some really complex way, different algorithms. How does a computer know, first question, if the patient has sepsis in your study?
Right. So I guess just one quick editorial comment. I think that you could absolutely, if you wanted to, and this is what a lot of companies might do, is take all the data you have, just run it through the algorithm and see what happens. But the problem is, I don't know if some people may be familiar with Google Flu Trends and the fact that, it did pretty well, at least initially, for predicting the flu that happened in the winter, but all of a sudden, it could totally miss the summer flu. And there's this maybe apocryphal story that like things related to high school basketball were strong predictors in the model. I don't know if that's actually true or not, but you can imagine that, in my mind, you need to be careful what variables you put in the model because of the fact that there are some things, first of all, that may change from year to year to year. And you want to be careful about how you do that. And there are some things that are going to be impacted by your intervention. And that's the other thing that you need to be careful about, because then that could cause this feedback loop. But what we've done for risk stratifying, we've just said, you know what, let's use ICU transfer, mortality, and cardiac arrest as risk stratifying, because that seems like a bad, a critically ill thing to happen to a patient, easily collectible everywhere. You can get huge data sets for that. For infection, it's a lot harder, which is why we've actually done chart reviews. We've done about 3,500 chart reviews now to identify infection. Luckily, the people who have done it have had very high agreement rates, which was our initial concern, but the agreement rates have been quite high. Because I think for machine learning algorithms, you need a goal, you need to try to get as close to gold standard as you can. And so for infection, we're trying to build that data set out.
Second question, kind of rolling into that, is do you foresee, if machine learning algorithms were to be rolled out, that it would be incorporated into an electronic health record like Epic to automatically work through your own patient population? Or like, how do you see this 10 years from now?
Right, so one of our algorithms is in a few hospitals now, and essentially it's used to identify early critical illness. So as soon as someone hits a certain risk threshold, then the rapid response team or the primary team, depending on the workflows of that hospital, are notified so that they then go see the patient. And so I think it really depends on what the workflows are at your individual hospital, what the culture is, and how you can sort of combine those things together with machine learning in order to add the most value you can. You don't want an algorithm that just sits there and tells you what to do. That will be an algorithm that's ignored. You want an algorithm that works within the culture, identifies the gaps in care, and really tries to act as a teammate to what the clinicians are already doing.
Thank you, Matt. Thank you, all of you guys. We appreciate it. And thank you to those of you in the Facebook universe, if you were watching. Have a good rest of your afternoon. Thanks. That was great. When you see Chris, be sure and tell him I tried to be very level-headed.
You were. I tried not to be too hard on surgery and stuff, but I didn't know how debating this would be, so I figured I'd.
Oh, I intended to lead off with that, to say.
Oh, hey, thanks.
I agree with you. It is worth geeking out, and I think actually once you go down the wormhole, it gets worse.
So, it gets worse before it gets better.
Was it built into Epic or something like that for you guys, or was it separate?
We have a separate. It's out because we wanted. Epic has some capabilities, but it can't do all the more advanced machine learning algorithms, and so we have a separate company that we partner with who can run all of these in the cloud.
All the data into.
Right.
That's cool.
Yeah, cool. Really appreciate that talk.
Yeah. Thanks.
Yeah, that's good talk. That's better every time.
Oh, well, we probably have more data. So
Yeah.
that's good. Sorry, I'm a resident. Hey, how are you? I'm Matt. Nice to meet you. Oh, go Buckeyes.
Oh, really?
Yeah, I'm from Ohio.
Okay. See, I'm not. So
Oh.
I don't even care. You know, like, I just reflexively Ohio.
Oh, good. Very good.
So, you report a lot of areas for your machine learning tools. What sort of sensitivities are you getting with those, and how does that sort of, like, how would those sensitivities in that situation compare?
Well, so the machine learning algorithms output a probability, or you can get them to output a probability, which means you actually have a value on every single part of the AUC curve. And so you could actually, if you want 100% sensitivity, you can pick that score. And so, you know, I think you could certainly, I think the most what you would want to do would be to look at that curve and then to look at SIRS in the dots where SIRS shows up and sort of match specificity on those same levels of sensitivity. So, you know, I don't have the exact numbers off the top of my head, but I can tell you that the false alarm rate is, you know, it's pretty easy to get a lower false alarm rate than SIRS without decreasing sensitivity by too much when you start adding, you know, 50, 100 variables into the model.
Yeah, for sure. Those variables. I would guess after
Yeah, I mean, you know, I think the most important thing is, you know, we're interested in developing models that are scalable to anyone if they want to use them. And so we start simple. We always present, if you just use vital signs, labs, age, location, and trends over time, how good is your model? And then how good does it get when you start adding things that maybe other hospitals don't have? So we always sort of show all those things. And you get 80 to 90% of the prediction power just from vitals and labs. And trends.
There's plenty of things like CRP, not necessarily everybody's going to, I think you mentioned that.
Yep, for the IPS, right.
Not everybody's going to have CRP. So, like, most of the variables that you guys are monitoring are something that are available.
Right, yeah, because we're really interested in getting this, you know, out to as many people as we can. We want to make sure that it's variables that anyone has in their hospital.
Thank you very much.
Yeah. Yeah, you're welcome. How are you?